Okay, Professor Shabaka, the session is on. You can take it from here.
Dr. Brown.
Greetings and good morning if you're on this side of the ocean, and good evening if you're on the other side of the ocean. The International Medical Exchange, in partnership with the International Society of Telehealth and Telemedicine and eHealth, are pleased to bring you the Artificial Intelligence for African Health Initiative. This is a global executive webinar series that we are kicking off today. It is really designed to engage the leaders and leading up to what we will call the AI4African Health Initiative Stakeholders Conference that we are planning to hold in April of 2027 in Morocco. And this series is really to help shape the strategic agenda that is going to align key stakeholders and build momentum towards the major continental convening. So this goal of this series is to position Africa not merely as a recipient of the digital health innovations, but as a leader in the ethical design, deployment, and scaling of artificial intelligence-driven healthcare systems that happens to be rooted in African ownership, local context, and sustainable implementation. I want to bring to you our opening remarks and strategic framing for the IME, International Society for Telemedicine and eHealth, and introduce you to our three guest speakers that will provide us with an overview keynote. I am going to introduce the three of them, and we will start by having our first professor to give us opening remarks. I do want to offer one housekeeping tip. If you have a question that you would like to have us discuss, I would ask that you would put it in the QA box, not in the chat box. Please allow that question that you have, make it brief, and put it in the QA box. We will try our best to get to all of the questions in the time that is allotted. We have a very rich agenda and we'll move from there. To introduce my first keynote, Professor Youngkap Kwankam is a world-renowned expert on digital health, and he serves as the chairman of Telehealth, Telnet Health International, CEO of Global eHealth, as well as the executive director for the International Society for Telemedicine and eHealth, as I've indicated. He is also the chief innovation advisor for IME. He has served in a number of capacities throughout the world. He has been a founding chief of eHealth at the World Health Organization, where he was the executive head of Global Observatory for eHealth. The next speaker that I'm going to bring to you is Dr. Sylvanus Ayeni. He is a retired neurosurgeon with several decades of experience in medicine and surgical practice. He is the president and founder of the Pan-Africa Children's Advisory Watch, and he serves as a board member of the International Medical Exchange. All of my speakers are very well recognized in the publication world. He, as well as Dr. Youngkap, have published several articles and books that may be of interest to all of you. Our third guest speaker is Professor Ruben Pillay, who is also globally recognized leader at the intersection of artificial intelligence, biomedical innovation, and the future of medicine. He is a professor of artificial intelligence and biomedical innovation, as well as the executive director of the Hersink Institute for Biomedical Innovation at the University of Alabama in Birmingham. Again, welcome to our keynote speakers. They will provide you with their remarks before we get into our panel. Thank you all so much for signing in to this very important presentation and webinar series. Professor Youngcap.
Thank you very much, Dr. Brown, for that warm introduction. Could we have the first slide, please? No? Well, yeah, while we're waiting for the first slide, let me just add a few words of welcome to everyone joining us today, whether on the continent or beyond it. And on behalf of both institutions, I'd like to welcome you to this webinar. The IME and ISFTH convened this session as partners, bound by a shared memorandum of understanding and a growing tri-institutional collaboration on AI in healthcare. So today is not a first encounter between our two institutions, but a natural extension of work already underway. We've gathered under one theme, one sub-theme, and one deliberate focus. The theme, harnessing artificial intelligence for health equity and universal health coverage in Africa. The sub-theme, digital public infrastructure for health. And the focus, stated plainly and clearly in the invitation to you all, building continental momentum across all 54 member states. I want to share with you three things. I want to tell you why this symposium is happening now, not a year ago or a year from now. Framing what we mean by our theme and sub-themes in terms of what you can act on, and setting out what we hope this day produces before it closes. Slide 2, please. Yeah, the timing is not incidental here. Just weeks ago, WHO, the Regional Office for Europe, and the government of Portugal co-hosted a global health level conference on AI in health, bringing senior officials, regulators, and multilateral partners together to translate political commitment into practical, equity-oriented action. That conversation was global. Ours today is continental, and it needs to be, because Africa's starting conditions, opportunities, and risks are distinct enough to demand their own forum. Africa's own institutions have not been standing still. At the African Union Summit in February this year, heads of state endorsed a continental health data governance framework led by Africa CDC, an agreement among member states on the legislation and regulation needed to govern health data equitably, including cross-border data flows, and any serious AI strategy depends on that. That same summit appointed Ethiopia's prime minister as the African Union's champion for digital transformation and artificial intelligence, signaling political commitment at the very highest levels of continental leadership. Then in April, Africa CDC brought member states, UN agencies, and technical partners together to validate a primary healthcare digitalization framework, a continental roadmap around continental health intelligence architecture, including a central data repository, an AI analytics layer, and anchored in the kind of interoperability of digital public infrastructure that we will need. We'll spend some of these days talking about. Next slide, please. I raise these points not as background, but to make a point that should shape how you listen to the rest of this symposium. We're not starting a conversation from zero. We are joining a continental agenda that already has legal instruments, political champions, and technical architecture in motion. The Malabo Convention, the AU Data Policy Framework, the Continental AI Strategy for 2024 to 2030, the Global Transformation Strategy for Africa. What is missing is not the framework. What is missing in most member states is the operational capacity, the financing pathway, and the technical partnerships to turn continental frameworks into deployed systems on the ground. That is a gap that this symposium and the ongoing work of IME and ISFTH as partners is built to help close. So let's turn to the theme itself, harnessing AI for health equity and universal health coverage. Let's start with the numbers that have defined African health financing for decades. Our continent carries roughly a quarter of the world's disease burden, while historically accounting for a small single-digit share of the global health spending and research investment. That imbalance is precisely why the arrival of AI in health is not a neutral event for Africa. It can widen the equity gap, or it can close it, or help close it. And which outcome we get depends entirely on choices made in gatherings like this one. The WHO-led Global Initiative for AI for Health, a joint effort of WHO, the ITU, and the World Intellectual Properties Organization, organizes its work around three pillars: enabling governance and standards, facilitating a global community of experts, and implementing sustainable AI models on the ground. Its RISE framework speaks directly to our continent's realities: robust capacity building, inclusive research, smart infrastructure, and equitable data practices designed explicitly to help low and middle income countries adopt AI responsibly rather than simply importing it. Recent public health literature has framed the choice facing Africa as a genuine fork in the road. One path is fragmented, pilot-driven adoption, dozens of small AI projects, each produced separately, procured separately, each training on data skewed towards urban populations with regular facility access, each vulnerable to vendors' lock-in that leaves health systems dependent on tools they cannot afford to sustain or replace. The other path is governance anchored, deliberate, coordinated, built on shared standards with equity monitoring built in from day one rather than retrofitted after harm is discovered. For universal health coverage specifically, we should be candid about a hard truth. Artificial intelligence cannot substitute for the basics. A predictive model does nothing for a clinic with no electricity. But paired with the functioning primary care, and Africa CDC has set a target of digitalizing 90% of primary healthcare systems by 2035. Paired with that, AI becomes a genuine force multiplier, extending the reach of a thin health workforce, supporting frontline decision-making, and helping communities' health workers do more with the tools already in their hands. This is our theme in practice, not AI for its own sake, but AI harnessed deliberately on African terms towards the equity and coverage goals we have set for ourselves. Next slide, please. Which brings us to our sub-theme, Digital Public Infrastructure, or DPI. DPI is a deliberately unglamorous term for something essential. It is not any single application, dashboard, or AI model. It is a shared fundamental layer behind all of them, the roads and rails rather than the vehicles that travel on them. In health, that foundational layer has three recurring components. Identity is one, unique health identifiers, so a person's record follows them across facilities and borders. Two, data exchange, interoperability standards and registries that let systems talk to each other and share. And three, shared platforms, national and increasingly continental data infrastructure that individual countries do not have to build alone. Africa CDC's own continental health intelligence architecture is a live example of DPI first thinking, a central data repository, an AI analytics layer, a continental interoperability standards, and designed so 54 member states are not each independently negotiating 54 separate procurement processes with different vendors for functionally the same infrastructure. Complementing that, the first mile, and I differ here from what's traditionally called the last mile, is the ambition behind initiatives like Health Connect Africa, working to connect tens of thousands of health facilities and equip millions of community health workers with the devices that make any of this usable in practice. Here is why DPI framing matters strategically and why we chose it as our sub-theme rather than simply talking about AI tools. Infrastructure shared across countries is infrastructure that is cheaper per country, more interoperable across borders, and far less exposed to the vendor lock-in and data sovereignty risks that come with each country going it alone. The legal function for this already exists on paper, and that's the Malabo Convention on Cybersecurity and Data Protection, the AU Data Policy Framework, and the Continental AI Strategy. The unfinished work is operational, turning that legal architecture into functioning systems that a health worker in a rural clinic actually touches. That is where organizations like ours have a role to play, not as owners of the continental infrastructure. That role belongs to the African institutions and member states, but as technical partners, capacity building conveners, and bridges between global standards setting bodies and country level implementation teams. Next slide, please. Which brings us to specific focus that we want to address today, building continental momentum across all 54 countries, not a subset, not a pilot cohort, all 54. Africa CDC's own financing strategy set out in what it calls the Green Book on Reimagining Health Financing rests on three pillars: increasing domestic investment, procuring innovative financing, procurement and innovative financing, and strengthening governance. Self-reliance in that framework does not mean countries closing their doors to partners. It means partners like IME, like ISFTH, engaging differently as technical assistance providers, as capacity building partners, as connectors between global expertise, including the HBCU institutions, for example, AI working groups, and diaspora medical networks that IME brings to the table, connecting all of this to the community level or country level teams working on actual implementation. The ISFTH standing as a non-state actor in official relations with WHO and its multiple year work developing policies, briefs, and funding strategies for donor engagement in this space. IME's network and its own tri-institutional collaboration on AI in healthcare. These are not separate entities running in parallel to today's symposium. They are the working infrastructure behind it. Today's symposium is where that behind the scenes work becomes a continental public conversation with the people who will actually carry these frameworks into their own health ministries. Momentum across 54 member states does not happen by decree. It happens one country conversation at a time, multiplied by coordinated convening like this one, anchored to the continental frameworks already in motion, and sustained by financing and technical partnerships that outlast any single symposium. Next slide, please. Keep going. Keep going. We think we've way past that. Right? Go on. Okay. Yeah. Next. That's correct. There we are. So here is what we're asking of you for the rest of today. First, come with your country's specific entry point in mind. That continental architecture we described is not a one-size-fits-all. So where does your health system sit today? And where is the highest value next step? Second, treat this as a working session, not just a webinar. The panels that follow are built to surface concrete national priorities and technical questions, not simply to present. Use the floor. If you're a speaker, or the chat window, the question and answer window, we've been told, to share your thoughts. Third, leave a connection you did not have this morning, whether this is a technical partner, a peer from another country facing the same challenges that yours is facing, or simply a link into the ISFTH and IME networks. That is success for today, as much as any resolution or communique that we can produce. We intend for today's discussion to feed directly into an action-oriented output, a shared statement of commitment and priorities that both IME and the ISFTH will carry forward in our ongoing engagement with the WHO, with Africa CDC, and with country health ministries in the months ahead. Next slide, please. So in closing, to our hosts at IME and to the ISFTH leadership joining from around the world, and to every participant here today, thank you for making the time for this conversation. The frameworks exist, the political commitment exists. What this symposium is here to build is a continental momentum to carry them forward together. Welcome once again to Digitization for Health in Africa. I thank you.
Good morning, good afternoon, good evening. On behalf of International Medical Exchange and our partners, I welcome you all to this event. This remark will be anchored on two themes. One, national, regional, and continental vision, unity, implementation of agreements, and treaties, which in geopolitical lingo we may call Pan-Africanism. Today, the world is by and large organized into major, powerful, and reasonably well-administered blocs. The US-Mexico-Canada Agreement in North America, the European Union, the North Atlantic Treaty Organization, NATO, the Comprehensive and Progressive Agreement for Trans-Pacific Partnership, a trade agreement among 12 nations in the Pacific Rim and beyond. In Asia, we have the Association of Southeast Asian Nations. In South America, we have Mercosur, which focuses on trade, economic cooperation, and to a lesser extent on political dialogue. Thus, Pan-Africanism is more than a political slogan. It is a powerful economic, social, and cultural force, and arguably the most potent tool for integrated development and competition with other continents. Just a brief history. The prominent 19th century Pan-Africanists were Martin Delany and Alexander Cromwell of the United States and Edward Blyden of Danish West Indies, now the American Virgin Islands. The early 20th century featured the Pan-African Conference held in London in July 1900, and 3 Pan-African Congress meetings convened in Europe, Paris in February 1919, and concurrent sessions in London, Paris, and Brussels, and again in London and Lisbon, Portugal, in 1921 and 1923, respectively. The 4th Congress, largely organized by women, was held in New York City in 1927. At the 5th Congress in Manchester, England, in October 1945, for the first time, representatives of political parties from Africa, including several future leaders of the continent, were present. Now, fast forward to the immediate post-colonial era. In 1961, 2 groups were formed by the founding fathers of newly independent African nations. The Casablanca Group, consisting of 7 countries, believed strongly that an immediate politically, economically, and militarily united federation of African nations was the formula for true emancipation of the people and flourishing of the continent. Prime Minister Kwame Nkrumah of Ghana was the most vocal exponent of this approach. The Monrovia Group of 20 nations also believed in Pan-Africanism. However, they were not in favor of an aggressive push for a federation of African nations. They favored a cautious approach of prioritizing national sovereignty and gradual cooperation. Eventually, the 2 groups joined to form the Organization of African Unity, OAU, in May 1963, and on July 9, 2002, at the Durban Summit in South Africa, the OAU officially became the African Union. So, the quest for de facto Pan-Africanism has been ongoing for more than a century. Today, the spirit is still there, no question about it, but serious gaps remain. And I will just give 3 examples. First, The 2001 Abuja Declaration, in which African governments committed to allocating at least 15% of their annual budget to improving the healthcare sector. More than 2 decades later, only a small number of AU member states have ever hit that 15% target, while many allocate substantially less than the minimum 15% they signed on. Second, the Malabo Convention that Professor Kwankam mentioned twice in his opening remarks is the AU's major continental treaty on cybersecurity and personal data protection, an important part of the legal framework that will help govern the data environment in which AI operates. Yet, less than half of the AU's member states have ratified it. Third, Article 19 of the African Union Constitutive Act provides for 3 financial institutions, including the African Central Bank, ACB. More than 25 years after the act entered into force on May 26, 2001, the ACB has still not been established. However, as of 2026, the AU is continuing efforts towards its establishment, including the creation of the African Monetary Institute as a precursor to the ACB, and we hope that that will accelerate. Now, AU member states have adopted national AI strategies and are embracing the continent's digital and AI transformation framework, both rhetorically and at the institutional level. Egypt, South Africa, Mauritius, and Rwanda stand out. A second, more heterogeneous group, which includes Cabo Verde, Senegal, Ghana, Nigeria, Morocco, Kenya, and increasingly Zambia, has demonstrated significant momentum. Nevertheless, implementation of AU continental frameworks and broad large-scale applications remain uneven and insufficient. The second theme, natural neurons and artificial neurons, their capability and roles. The development and maturation of our natural neurons proceed through our time in the womb and continue for decades after birth. Each one of us has 86 to 100 billion of them and hundreds of trillions of neuronal connections. AI systems can process vast amounts of digital data far more rapidly and in much larger volume than the human brain. However, artificial neural networks, which power modern AI systems, have no blood supply, no cerebrospinal fluid, no emotions, they do not feel pain, they have no consciousness, no traditions, and no lived culture. Most critically, they have nothing comparable to the default mode network, DMN, a large-scale intrinsic brain network which is active at rest and integrates autobiographical memory, self-reflection, mental stimulation, mind wandering, and future planning. Consequently, the basic infrastructure to improve and expand healthcare services across the continent, namely stable, reliable, continuous electricity, clean tap water, good roads and bridges, sanitation and sewage treatment systems, and public safety, just to mention a few, cannot be delivered by artificial neurons. Yes, there is AI-assisted radiology, AI-assisted pathology in low-resource laboratories, outbreak prediction models, chatbots for primary care triage, and supply chain optimization. Also, AI agents increasingly exhibit capabilities which are functionally similar to some processes associated with our brain's central executive network, CEN. Some of their performances even bears some resemblance to functions attributed to salience network, SN. But the comparison certainly has limits. As far as I know, no current AI system reproduces or can replace the complex functionality of human neuronal networks. Therefore, we must resist the temptation to believe that AI can get us around profound, basic foundational deficits. Artificial neural networks must not become the default mode network for elevation and enhancement of Africa's healthcare systems, and indeed, any development sector in Africa. Thank you very much, and please enjoy these sessions.
Okay, so I guess, yep, it's I'm coming up. I'm just trying to load my screen. Please let me know if you could see that.
Yeah, we can see.
Yes.
You can see the screen.
Yeah, we can see.
Oh, good. So thank you very much. I really am appreciative of the opportunity to address this fantastic audience. I love the opening segments, and I'm enthused by the plans to start leveraging artificial intelligence in Africa, and of course the rest of the developing world. I've got kind of 30 minutes with you, so I'm going to go through this pretty quickly. I want to talk about, in broad, the opportunities that artificial intelligence presents for us in not just Africa, but across the globe with low and middle income countries. I also want to make very clear that there are significant threats that artificial intelligence will pose to us, both from a socioeconomic perspective, and we have to be really cognizant of that, because if we don't really manage that astutely, we could arguably see the biggest crisis, political and otherwise, especially in a continent like Africa. Having said that, I'm a strong proponent of artificial intelligence. I think the problems that we talk about, I saw the audience is a pretty mature audience, so we've all been around a long time. The challenges and problems that we've been talking about in health and healthcare have been the same for tens of decades. Okay, we talk about the same thing: cost, quality, access, patient experience, staff experience, workforce issues. These issues have never changed for centuries. That's a fact. Okay. And there are many reasons for that. But having said that, I think we are uniquely positioned now for the first time to address all of these challenges simultaneously, given the potential that artificial intelligence and innovation and digital transformation offer us. So, I am optimistic, but I'm very guardedly and cautiously optimistic. Because, in healthcare, we have we don't have a really good reputation in leveraging technology to improve health and healthcare. And this goes way back. 1847, I guess, was one of medicine's greatest innovations. You have to wash your hands to reduce the probability of infecting your patients. Dr. Ignaz Semmelweis, proved that if you washed your hands before you deliver a baby, maternal mortality will drop by 90%. He said this in 1847. And what did we do as a profession? We resisted it. We called him crazy. to the extent that we actually committed him to an asylum where he died 30 years later of septicemia, before hand washing became mainstream. So that's the profession we're in. I often describe our profession as being a cult. It's extremely difficult to change, and we're fixated in doing things the way Hippocrates did it, despite changing environments and contexts. Okay, this may surprise you. The stethoscope was developed in 1816 by French physician René Laennec. Okay, physicians resisted this. It took 30 years before the stethoscope was embraced. And the reasons they gave in 1816, the fact that the stethoscope is going to actually intervene and impact the doctor-patient relationship, because historically, physicians held their ear to the patient's chest. And they regarded the stethoscope as something that's going to create distance between the doctor and the patient. They resisted it. It's the same discussion we're having today about artificial intelligence, that it's going to dehumanize the practice of medicine. It took us 30 years before the stethoscope was accepted as a critical tool in medicine. Now, just keep these two cases at the back of your mind as you start, having discourses about the potential of artificial intelligence and the impact that it could have. Okay, as we're not an easy profession. We're not a profession that unlearns easily. We're not a profession that changes its approach to doing things easily. So despite the potential that technology has, healthcare has never actually improved cost, quality, access, workforce experience, patient experience, despite significant technology innovation over the decades. Okay, so as I said, I'm extremely optimistic, but guardedly so. I think the evidence is pretty, I don't want to go in about does AI work or not. That ship has sailed. The evidence is in. AI works, and it's proving to be significantly better than humans. Now, if you look at this slide, I think it summarizes the performance of artificial intelligence generally over the last decade. In pretty much every cognitive domain that's listed at the bottom, AI has superseding human performance. And the observation from this slide is pretty stark, that it's happening really quickly, and most cognitive domains are surpassing the human baseline. Now this graphic does the humans, more justice than they deserve. We know that the human baseline doesn't stay static at 100%. With age and data overload, that baseline drops. Whereas with artificial intelligence, with time and with data overload, that improves. Okay, so we're already reaching, or we pretty much are at a point where AI generally is surpassing human cognitive ability. And if you look at these lines where they'll converge, I think they'll converge past the human baseline in about 2 years' time. And that's going to usher in the era of artificial general intelligence. Okay, this is where AI is as intelligent and cognitively sound as humans. And I think we're about a decade away from that point, from artificial superintelligence, where AI is far superior to humans. Now, I just want to remind you that humans, in all of human history, have never coexisted with anything that's as intelligent as they are. And even worse, we've never coexisted with something that's more intelligent than us. So all of these issues we kind of grapple with AI, and as I move from meeting to meeting or strategy session to strategy session, and this, by the way, is one of them where we're looking at AI in healthcare. I think the big guys in the room have to also start having bigger discussions. What happens in 2 years in artificial general intelligence? What happens in a decade from then with artificial superintelligence? Because this does not only have healthcare consequences, it has humanity consequences, where we're going to grapple and fight to remain human in an era where we're coexisting with something smarter than us. So bear that in mind. As far as biomedical sciences go, I think the evidence is, as I said, it's in. If you look at the number of FDA approved and CE approved devices that kind of increasing astronomically. AI is making significant inroads in actually the biomedical sciences and drug discovery, structural biology, and in clinical performance. There's not a day that goes past without a publication, with findings that AI is starting to surpass physician performance. So across the board, we're starting to see this. One of the biggest disruptions that I don't have time to talk about is how AI is going. And one of the biggest opportunities for Africa, by the way, is using AI to disrupt the biomedical research process. Okay. An agenda that historically required significant amounts of specialized human resources and specialized and high financial investment, all of that is going to be done away with. So it offers a perfect opportunity for Africa to take the lead in biomedical research automation. As I said, the data there's significant data demonstrating that AI is better than radiologists, AI is better than pathologists, better than dermatologists, really better at sepsis prediction and predicting conditions. By the way, all of these are peer-reviewed publications published, and the list is long. Okay, the list is long, demonstrating that AI supersedes human performance. One of these that really excites me was a publication in 2026 where AI was able to predict the onset of pancreatic cancer about a year and a half before onset. Now, for the physicians in the room, you'll understand the importance of this. Okay, once you're diagnosed with pancreatic cancer, you have 6 months at the max. Okay, so this ability to predict an onset of a disease or an affliction 18 months before it manifests is really an advance. And I think this ability to predict is going to usher in a rethink of medicine. We're going to kind of see the introduction of preventive interventional surgical disciplines, where we're starting to do interventional surgery without the condition even manifesting as well. I think we really are pretty much, I don't want to ask the question, but I'll be very surprised if everybody on this call, all 229 of you, are not using some kind of large language model or some AI. So adoption is being ubiquitous. Arguably large language models have been the fastest growth in adoption, even compared to Facebook, TikTok, Instagram, and all of that. It's just exploded. Even in medicine, if you ask physicians, about 72% of them say they use it. 35% of them actually admit to using it in clinical care. And just recently, as I said, these publications are pretty much daily. One publication that compared large language models to physicians demonstrated pretty compellingly that these models outperform physicians. Okay. Now, I want you to be very, very wary of these publications. Be very wary, because a lot of these data publications, researchers currently do not withstand the rigor that's necessary. The rigor that's necessary. Now, if you look at all of these studies, pretty much 100% of them are based on case vignettes and simulations and actors as patients. So all the data, all of the hype around how good AI and large language models are, even if they're FDA approved, if you drill down, the methodology does not hold. So be very wary of that, okay? We also had published in February this year where AI was used to triage patients. And you could see in this data, it tends to over triage patients who have to be treated at home and under triage patients who need urgent care. That's a problem. Okay, it's a serious problem. And if you look at this trial that was published in Feb 2026, where they randomized large language models versus patients, you could see with the large language model alone, the performance is really good. But when real patients use it, the performance drops. Okay, so, despite all the hype and the excitement about the potential of artificial intelligence, I want to warn you, we are really living in a paradoxical time where validated AI that works, machine learning and deep learning solutions to identify, predict septicemia, identify nodules, predict the onset of cancers, etc. All of these are validated. Most of them are prospective studies, real patients. You'll be hard-pressed to find them deployed in any health system. And I work in the USA's 5th largest health system. We're not deploying a single of those validated models. But if you ask my 7,000 physicians, almost 100% of them are using ChatGPT or Claude Open Evidence, which has got no significant evidence. So I kind of call this, and I write extensively about this. We're living in a paradoxical situation where models that work are not deployed, and models with insufficient evidence are ubiquitously used. That is a governance issue, and that does not augur well for the future of medicine and science. So just be warned, and that's the situation we face in the current situation. So there is an issue with autonomy. There's no doubt about it. In the USA now, autonomous vehicles are available everywhere, taxis, etc. In most countries most states have it. But I'll just remind you that the concept started 17 years ago. Okay, so it took 17 years for autonomous driving to go from concept to deployed. Okay, and I would say, about 5 or 6 years into this AI in medicine kind of time frame. So, as I said, I'm confident if we manage this appropriately with expectations, given what I just said to you, and put in place the necessary governance structures for that, then we can get it right. Self-driving vehicles, as I said, are pretty ubiquitously used now. I'm going to move into the next phase. I'm terming this, the now to next. A lot of the way I see the future panning out has kind of already begun. It's already happening in some shape or form. And what I want to focus on is, well, how is this convergence of artificial intelligence and digital technology going to shape the future? Okay, and the first big trend I see is what I call prosumerism. Now, I coined this term to describe the patient of the future. I think the patient of the future is going to be, a patient who is not a passive recipient of care, as they have been historically, is not a consumer who's an informed purchaser, as we're starting to frame them now. A prosumer is a technology-enabled producer of care. Okay, so they're going to deliver their own care. They're not customers of our health system anymore. They're competitors. And seeing your customer as a competitor means that you have to radically rethink your business model. And we're kind of seeing this across the board. I don't have to go into every single technology, but we're seeing FDA CE-approved technology starting to become available to patients now, enabling them to deliver services that were historically the purview of medical specialists. Okay? They can do everything. They can do their mammograms at home, get interpretations. They can do full clinical assessments. They can do dental assessments. They can diagnose skin conditions. You know, if they have cardiac conditions, they can, there's a commoditized FDA-approved ECG that they could use. You couple that with AI, they actually get a 6-lead EKG all at home. If you need a 12-lead EKG, you don't have to go to the hospital. Patients can use it at home. This, folk, is super specialty cardiology now available to patients at home. So they're not patients anymore. They're producers of care. You know, you can diagnose cardiac failure, a pretty common condition, at home using a smartphone. And all of these functionalities are already in the phone. You know, remotely monitoring patients with cardiac failure. We can now use computer vision to achieve that. A little camera that sits at home can detect, you know, patients who kind of are being, you know, going into or worsening cardiac failure. I always show this is optometry. You know, you don't need to go into an optometrist anymore. Buy a little device, attach it to your smartphone, and you could do your own ocular assessments. One device, you know, could serve the neighborhood. And this only costs $30. So irrespective of which part of the country or world you are, it's pretty affordable, isn't it? Now, these folk are not patients. They're prosumers. You know, we're starting to see increasingly the commoditization and the democratization of access to specialty technology like eye check. Essentially, this is a tool that does fundoscopy, okay? And it could be placed anywhere. Pharmacies can have them, doctor's offices, you know, your local gas station, corner shop can have them. And this is really important technology, by the way, because, you know, a simple fundoscopy can give you significant amounts of information. Now, imagine all of these diagnostic capabilities. By the way, this is a term I use for this, is the advent of opportunistic screening. Available where patients are, when they need them, and if the business model is right, at a price approaching zero. Okay? This stuff is not coming. It's here. And it's driving what I call prosumerization. You know, I'm a big proponent of oral health being health. And for some reason, these two specialties are diverging, and I think they should start converging. And there's significant opportunity there as well, because it's easy to get access to the mouth for prosumerist technologies. And we're actually starting to work with them. And, you know, we're actually working very closely now with dental schools and oral health programs to use technology to access the mouth as a source of diagnosis. You know, historically, people would have to go to a clinic or hospital for x-rays. Not anymore. Okay, it's commoditized now and available. You couple this with AI, it could actually interpret your x-rays as well. Have you ever thought of x-rays being commoditized in every household or every neighborhood or every school having their own x-ray machines? As I said, this is pretty powerful, you know, because it enables us to perform opportunistic screening. I'm not sure if you know the amount of information and data you can get from a simple chest x-ray, the commonest diagnostic, okay? You could see on this graphic the different diagnoses. We can diagnose diabetes, cardiac risk, and liver disease, a whole host of conditions, just from a simple chest x-ray, okay? Humans don't have the cognitive capability to do that. You know, you may argue, well, for some tests you have to go in. Well, not really. Even for a colonoscopy, you could actually get a pull cam, and the advent of DIY colonoscopies are already here. Okay, what you're seeing increasingly is the incidence of colon cancer going up. More importantly, the whole point of screening after 50 is out the window. Patients are getting afflicted with colon cancer at a younger and younger age. And our system is not designed to start screening younger people. We just don't have the capacity to scale to do that. So for about $99, which is about 1,500 Rand, and whether you convert it irrespective of the part of the world you'll agree that it's a pretty good deal to get your own colonoscopy. Same for gastroscopies, really expensive procedure, resource intensive, has safety issues, pretty expensive, and most scary, 80% find no disease. Okay, so that's not. It just means that we're doing expensive investigations without any significant ROI. But the same thing, the pull bot is discovered, skip breakfast, swallow the bot, 10-minute procedure, instant diagnosis. And the pull bot costs $40. Okay, so this concept of prosumerization, I think, is going to become the de facto way that medicine is going to be practiced. Ideal for LMIC countries because we can actually leapfrog this kind of system hospital-based medicine. Because to be honest with you, the model does not work. Okay, the hospital as a model to deliver care may have been relevant during Hippocrates and just after. Today, that model does not work, and we continue to build on that. I also, my team is working on a project called Healthion, and this is essentially a device to enable patients to maintain their own EMRs, their own records. So it becomes available to them when they need it, and it's up to them to share with who they want to. Why should a hospital who has the EMR own your data? It's just a database, but why should the hospital own it or the EMR company own it? Why should they monetize it? Why should they use your data to develop AI solutions and sell it back to you? That's a nonsensical approach. So we launched Healthion, where you actually hold your data, belongs to you, you have a personal cloud account, and you decide who to release that data to. So, we built this on, and this is to leapfrog the EMR industry, especially for LMIC countries. Instead of investing hundreds of millions of dollars to just set up what's in just a database, we don't need that anymore. We have technology to enable patients to hold their own medical record, and they can share the record whenever they need to. And as you can see here, we've created a model where they can actually, if an AI company wants to use their data to build a solution, well, you're welcome to buy it from me. If a pharma company wants to use my genomic data to find drug discovery, sure, you can build it. So you can see it has a wallet, and every time you voluntarily share information, be it with a hospital system or with a vendor or with industry, you get paid. Okay, so you're going to see us moving in that. If somebody, there's a clock running. Okay, we're also going to see a physician transformation. I think the biggest impact, and really important where there are workforce issues, is AI's biggest impact is not with the specialists or the general practitioners. The lower level healthcare professionals are the ones who are going to be the biggest beneficiaries. So strategically, when you're designing and thinking about AI as it relates to workforce, your impact is highest with community health workers, with nurse practitioners, and the junior physicians, not with the specialists and super specialists, etc. So that's really important strategically. I think you're also going to see, clinician transformation. I think this is really important in how we train the future generation of doctors. They're not going to be who we are today. They're going to be what I call physicianeers, half biomedically trained and other half digital and technology trained. And a physician here is somebody who works well with biomedical, biological data, but also works really, really well with data science, artificial intelligence, and they combine this. So it's a combination of a traditional physician and with an engineer. That's the new breed of physician that we have to start creating. I also think AI is going to usher in what I like to call omni-specialists. Why should we have specializations if AI has the ability to process all the information? Okay, so I think you're going to see the future move away from a specialist to omni-specialist, where your endocrinologist is also your cardiologist, is also your neurologist, is also your geneticist. They can do everything. I can do it. I can do it now as a family physician. I can, give my patients super specialist cardiology advice, super specialist endocrinology. I can do it. Okay. So why should specialists exist? I think that's going to change. We're also going to see specialists becoming automated. The reality is, as I said, despite all the concerns I have, the reality is the trajectory is pretty obvious. We're moving into automation, where all of these issues I raised about validation, etc., they're going to be addressed. And you're going to move into an era where you would have multi-agent, fully autonomous care delivery, and that's going to really, reduce cost to zero, improve access to 100%. So pretty much AI should be a workforce strategy. I think we can do it. One of the things that's going to have to change is our workflow. We're going to have to radically rethink how we design the workflow. Okay, our current approach is, it will not work with artificial intelligence. So we're going to have to change that. I've been writing pretty extensively recently on AI native design workflows because they're going to have to change. If we don't change workflows, we're not going to be able to benefit from the advantages of healthcare. All of you are trained on SOAP, subjective, objective assessment plan. We have to do away with that. Okay, AI, in the context of AI, the model has to change. So the cult that I talk about, this cultist behavior in terms of how we design clinical and workflows, will have to change if we're going to really benefit from artificial intelligence. I'm not going to spend time, but as I said, there's a lot of my writings out on that. We're going to see system transformation, a lot of virtualization of healthcare. This is an example of a solution. We have radiation planning assistant. One of the big constraints in oncology globally is access to radiation oncologists. I can't see the time. How many more minutes do I have there? If somebody could just help me.
Your time is up, actually.
Oh,
So
okay, Doris. So I'm
come
going to stop there and take questions if I have to. How's that? Yeah.
Thank you.
I will stop sharing. Yeah, I can see the time. So yeah.
Professor Yankam, you're back on.
Yes, Doris. Professor Brown, Dr. Brown.
I think you are going to your first panel now.
Yes. Well, we're waiting. Thanks to Dr. Ruben Pillay. Wonderful talk.
Thank you.
We'll have questions at the end, I believe. Thank you.
All right. Shall we begin the panel, Dr. Brown?
Yes, I thought that Professor Yankam was going to introduce you. Dr. Randall Morgan, President and CEO of the Cobb Institute, and he will introduce his first panel that's going to address public health and disease surveillance in AI.
Thank you very much, Dr. Brown. And good day, everyone.
My name is Dr. Randall C. Morgan Jr., and I will be the moderator for the first panel of this important webinar. I serve as the president and CEO of the W. Montague Cobb NMA Health Institute and serve as an organizing partner for the International Medical Exchange webinar and other programs. This panel today is our first panel. It is entitled AI, Public Health, and Disease Surveillance, including the WHO Afro and the Africa CDC perspectives. The goal of the panel will be to describe the intersection of AI and public health and disease surveillance throughout the continent of Africa and what our panelists perceive as the future. I'd now like to introduce to you our three panelists. Each of our panelists will provide introductory remarks that speak to the title of this panel and to the roles that they play as content experts related to AI and public health in Africa and globally. Our first panelist is Dr. Derek Munine, who is the team lead for the Digital Health Assessment, Planning, and Partnerships. An Insights Capacity and Operations Unit of the Department of Data, Digital Health, Analytics, and AI at the WHO headquarters in Geneva. He has 25 years of progressive experience in global digital health, global public health informatics, digital health governance and literacy, and digital health capacity building. Previously, he served as the regional eHealth and eHealth advisor for the WHO Regional Office for Africa, where he supported 47 African countries with the adoption of eHealth strategies and eHealth solutions. Welcome, Dr. Munine. Ms. Precious Matsoso is our second panelist. She is currently the director of the Health Regulatory Science Platform, a division for WIT's Health Consortium, and was an honorary lecturer in the Department of Pharmacy and Pharmacology at the University of Witwatersrand. She formerly served as Director General for the National Department of Health by the President of South Africa. She holds a degree in pharmacy and a master's degree in law and ethics. She served as Director in Public Health Innovation and Intellectual Property in the Office of the Director General of the World Health Organization. Welcome, Ms. Matsoso. Our third panelist is Professor Olakian A. Youthman, Professor of Global Health Informatics, Stellenbosch University, Center for Evidence-Based Healthcare in South Africa. He also serves as Distinguished Professor of Global Health Informatics at Warwick Medical School, University of Warwick. Professor Uthman is a pioneering researcher at the intersection of artificial intelligence, machine learning, and health. His work focuses upon innovation, computational methods to address clinical health challenges in resource-limited settings. Welcome, Professor Uthman. Each participant on our panel today has a deep understanding of life and the academic skills necessary to make a difference in our community. Professor Youthman will be our first speaker today and speak with a focus upon the potential role of AI in addressing critical health challenges in resource-limited settings. Dr. Uthman.
Thank you. Let me share my screen, please. Thank you very much, Dr. Morgan, for the introduction. So the title of my talk, the introduction is, I'll be focusing on disease surveillance, and I've sort of titled as saying it sooner, acting faster, and owning the system. Why is it important for us in Africa to focus on AI, in public health surveillance now? As we all know, traditionally, health issue in Africa has been mainly on infectious disease, epidemic disease, but now there's issue of rising chronic disease condition that is sort of burdening the workforce. So the health workforce is have more work to do than previously, because now people are coming down with non-communicable disease, cancer, cardiovascular disease, and heart disease generally. And again, traditionally, before, we don't used to have huge set of data set now, but data is not problem in Africa now. We now have abundance of registry data, laboratory and genomic data. However, the main issue is the analysis lags behind. Most of the reporting is still paper-based and is still manual. So we need to do better to be able to have proper health surveillance. So what is holding us back? The main issue is sort of categorized into three areas. Now we have, the first one is on compute and connectivity. You'll be surprised that most of the global data center are not located in Africa. Just under 1% of global health center is located in Africa setting. And again, most of the models that have been discussed previously through the lecture, they were sort of imported from another setting, trained elsewhere, are not sort of relevant to Africa setting, language, and local epidemic. And most importantly, capacity. We still lack analytics aspect capacity to be able to use some of these advanced artificial intelligence that are available globally now. So in terms of pandemic and surveillance, an outbreak runs a clock. So this is what we want to sort of address in terms of when we talk about the surveillance and pandemic surveillance. There is this framework by Regional Strategy for Health Security and Emergencies. It says you have to detect emergency threats to detection within at maximum of 7 days. Then you should be able to notify the health system within a day, and you should be able to respond after notification within at maximum of 7 days again. So how can we use AI to sort of shorten this framework? So I will frame my discussion for this panel today by sort of posing these three questions. And for this continent in Africa, can we see this threat? Can we act on it? And can we own it? Though there are existing AI tool and facility that are being used to detect surveillance ahead of time in terms of early warning and forecasting. But the problem is, does it reach the edge facility on time? Using the routinely available data set, can we see the problem ahead of time? Can we see it before it becomes pandemic? And as we all know, the Ebola outbreak that is ongoing now, how can we do better to see it before it sort of starts? Then even seeing it, can we act on it? Do we have the facility to be able to sort of act on it? Are we sure there's a named person? If we detect something, can we pass it at the appropriate body? No, Africa is not lacking of AI. There are a lot of AI pilot systems, but we don't have AI systems. So we have pilot studies here and there, but we lack AI system to be able to act on these signals. And the last question that I'm going to pose that we'll be discussing across this panel one today is, for Africa to proceed and to be able to do this, we need to own this. So in order to own this, we need this four foundation. We need data, interoperable, standardized data set across Africa. Then the workforce, we need to train capacity, the epidemiology, data scientists, engineer to be able to do this. Then we need infrastructure to be able to do all this computation, develop some of this language model. And then we need governance in terms of the rule of consent. How do we share data between different countries? So those are Then finally, I mean, for my introductory talk is AI does not replace public health system. What we are saying is that how can we own this system so that it's strengthening, be able to act very fast and be able to detect pandemic before it occurs in Africa. So thanks. So that's for my introduction.
Thank you very much. And I'm certain that we will have questions about your presentation. And I have a few myself. And we would like to now move to our next speaker, who will be Dr. Derek Manunji.
Thank you so much for the excellent session that we're having today. I'll be loading my presentation now, and do let me know once you can see the screen. So let me share. Let me know once the screen is visible on the other side.
It's visible.
All right, thanks so much. So before I start, actually, I just want to point out that the conversation that's been put together by the two organizations is very timely. As was mentioned, particularly by Professor Yankap, we are in official relations with the International Society for Telemedicine and eHealth. And so this portfolio of work that is being discussed is relevant, especially in the times that we live in. We do have a lot of exciting energy coming out of our member states in as far as harnessing digital and artificial intelligence is concerned. There are 4 thematic areas that I'll be speaking to, and these are really about creating, or rather leveraging, the foundations that our member states have given us to diffuse the health system with the appropriate ethical and safe utilization of digital health intervention, as well as artificial intelligence. So I'll begin by recapping WHO's AFRO's own contribution to this particular journey, working with member states, providing the regulatory environment. And then I'll proceed to talk about the global trends in digital health and AI, then specifically deep dive into WHO's work on artificial intelligence more broadly, together with reflections coming out of our WHO hub in Germany, the Pandemic Intelligence Center. Then thereafter close with a bit of a deeper dive on the perspectives coming from the WHO Afro region. And the slides hopefully will be shared with the participants. I'll gloss over a few slides so as to ensure that the essence of the presentation is not lost due to the multitude of slides. So first things first, we are in the 5th industrial revolution, and WHO's AFRO's own contribution to this journey began, if you like, from 2010. This is within the overall framework of the global resolutions on eHealth. So WHO AFRO ministers in 2013 recognized the value of eHealth, and throughout the journey until now, WHO AFRO has put in place a framework for the harnessing of eHealth, and they've also put together a framework for the implementation of digital health in specific countries through the Global Initiative on Digital Health. They have also contributed towards the evolution of the next global strategy on digital health. Specifically, before the current hype on AI, in 2022, WHO AFRO launched the first ever ministerial session on the use of artificial intelligence in health. And in 2023, convened member states at a capacity building workshop to look at the ethics and governance of AI through a capacity building session. A few member states have showcased progress in the implementation of digital solutions at the global level. A case in point is the recent World Summit on the Information Society. So 2 winners, one in eHealth and one in e-governance. The eHealth winner came from South Africa. Here, they were demonstrating how government-led solutions that reach populations can be sustained by strong partnerships and at the same time government investment. So South Africa showcased their Mom Connect. From Eswatini, the e-government division demonstrated why connectivity is a key enabler for digitalization. So we cannot speak of artificial intelligence, electronic medical record system, if the enabling environment is not present. Just to also note that a number of member states, as was mentioned in the preamble, have begun to put in place platforms that harness artificial intelligence for disease surveillance. Zambia is a good case, is a good example, together through Rwanda, and many more that have put in place centers of excellence that support the disease surveillance agenda of countries. Let me pause here as we go to, as I proceed to reflect on the global scene. There are 4 member states on the African continent that have contributed to global movements on the digitalization of the health sector. And when I say digitalization, this includes the introduction of artificial intelligence. So Tunisia was instrumental on the formulation of the World Summit on the Information Society and e-government agenda together with Switzerland. Germany and Namibia were instrumental in the Pact for the Future of 2024. Zambia and Sweden were instrumental in the Global Digital Compact that has a segment dealing with artificial intelligence. And finally, Kenya and Albania were instrumental last year in the audit of the 20-year movement on the digitalization agenda. In terms of the global stage, it's been 20 years since we have been working with our member states on the issue of digitalization. And over the past 20 years, we have realized that the old challenges around digitalization are still with us. Lack of interoperability, lack of skilled health workforce, the issue of pilots, and many more challenges as were highlighted in the WHO Science Report. As Professor Yankap had mentioned, investing in foundations for any interventions, including AI, are critical. Thinking about financing, governance strategies, thinking about the workforce, and etc. We have since learned that many of the member states have put in place governance mechanisms in as far as the transformation agenda. There are still challenges around interoperability, around infrastructure, and there are still challenges around the whole issue of workforce capacities, as our last global observatory, as our last Global Digital Health Monitor survey actually shows. Just to point out that a number of member states in the African region have actually made progress in the maturity levels of the ecosystem. And these member states are actively looking at the actions to take to truly make digitalization save the people. And so as we look at the momentum that we're seeing with member states, we are working with member states to extend a global mechanism called the Global Strategy on Digital Health. Last year, member states convened. By the way, this year, member states convened to review the past 5 years of the global strategy and then reflect upon the AI revolution and the Global Digital Compact that I spoke about, and what to actually do to ensure that digital health indeed leaves no one behind. We saw member states speak to 5 things around governance and financing, architecture, infrastructure and systems, capacity building, and really harnessing artificial intelligence. These are key thematic areas that are going into the next global strategy on digital health. I'll pause here so that others can take the QR code. The next global strategy on digital health is up for consultation. This audience is welcome to pick the QR code, go to the website, review the current draft, and comment and add content to the to make sure that the next strategy is actually fit for purpose. It has 4 objectives around resilience and governance, around the issue of interoperability, issues around digital public infrastructure and capacity and partnerships, and lastly, fostering the responsible use of artificial intelligence and other emerging technologies. And so as we look at WHO specific work in artificial intelligence, allow me to point out, as Professor Yankap Kwamkwam had mentioned, that there has been a global movement in this agenda. We just came from the India 2026 AI Summit, which naturally gave birth, proceeded towards the UN Global Dialogue on Artificial Intelligence that was convened here in Geneva this year. This naturally has also proceeded towards the AI4Good Summit, which really focuses around the safe, ethical, and governed implementation of AI. And then lastly, there was a conference in Korea that brought together different players to look into the whole issue around the development of AI systems that serve the needs of the people, which are based upon standards with privacy by design implementation capabilities. Just to point out that next year we'll be inviting, we will be participating with Switzerland on the AI Summit in 2027. This month, again, you are invited to the third meeting of the Global AI Initiative that will be in China. The QR code is there. The date will be 16th to 18th. This is a global summit, third in its kind, that will look at actual implementation science of artificial intelligence. There are five key agenda items for WHO in terms of this field. We definitely we continue to harness our convening role in terms of bringing people together to discuss key enablers for this particular journey, especially when it comes to involving all players. We also continue to serve as the trusted norm setter, and we continue to ensure that what is discussed globally meets the ground. And as has been mentioned, issues of equity access and leaving no one behind remain essential, together with making sure that there's accountability. There are tremendous documents on this particular subject that has been developed by WHO ITU and our WIPO colleagues. So do go to the WHO website. You see tremendous documents on this particular subject, from ethics to large language models, to capacity building, to courses. Tremendous publications have been developed over the past 6 years that you're welcome to actually use and utilize in this particular journey. I just want to point out that we continue to work with our partners to just ensure that the field of AI, is equitably managed by our member states, is governed, but it actually ensures that it leaves no one behind. And so there are 4 strategic pillars. One deals with foundations, second deals with governance and capacity, then third deals with the whole issue of generating evidence, and then the fourth item is around making sure that the transformation of AI actually reaches as many countries as possible. I just want to point out that the WHO Pandemic Hub is a good resource. We just published in 2025 our report around the disease surveillance agenda of WHO globally, so feel free to go there. I'm just going to conclude by reflecting on WHO's Afro's journey. I did point out the 6-year journey on digitalization, but wanted to point out that there are key challenges that need to be confronted, issues around internet access, issues around broadband coverage, and also just making sure that we're not forgetting the foundation that makes AI and disease surveillance possible. We're still dealing with strategies that need to be updated, and we're also still dealing with fragmentation. And at the same time, we are still dealing with ensuring that countries are able to progress on their maturity progress. There are key things that need to be addressed. The whole issue around minimizing fragmentation, ensuring that countries have less reliance on donor funding, reduction in pilots, but also making sure that instead of thinking about the technology, we focus on the holistic approach of systems. I just want to point out here that this particular journey that we're discussing is at the right time. Member states are hearing, member states are keen, and member states have really opened the door for this dialogue to actually take place so that we can truly make sure that digital health does not leave anyone behind. Thank you so much. Merci beaucoup. Obrigado.
Thank you very much, Dr. Munine, and for painting such a wonderful picture of global collaboration, and also the broad amount of reference material and data that is available on the website for WHO. And I'm certain there may be some questions about that in our Q&A period. So thank you very much. Our final initial presentation will be by Ms. Precious Matsusu, and her focus will be upon the regulatory process with regard to AI and public health. Ms. Matsusu. Was she able to join?
I believe so.
Yeah. I mean, we have her presentation, correct?
That's correct.
Yes. So maybe we have a connection problem.
Would you go to a couple of questions
I
while
think
we're
what
trying to
we'll do,
locate her?
if we
Absolutely.
have,
Good idea.
yeah, do we have any questions that we can begin with? And
There are 4 in the Q&A right now, and Dr. Morgan, I just sent them to you.
all right. I'm sorry, but I cannot identify the questions. If could have some assistance, would appreciate it.
Josie, why don't you read the questions?
Okay, sure. So the first one, it's a little long, but it says, we already have a functioning, established national health information hub in Sierra Leone, consistent with other nations pushing for digitization in Africa. My question now is, all the countries deploying AI into our health systems, how many of them have a Health Data Protection Act? As a country, how prepared are we should a day come that we see this phase that page is not found in terms of a Health Data Protection Act?
Would either of you like to address that question? Perhaps Dr. Munine?
Yeah, thank you so much. Thank you so much. This is a great question coming from Sierra Leone. And I just want to point out that during the AI summit that I talked about from 2022, it was the then Minister of Health in Sierra Leone that spoke very articulately on the issue of making sure that AI is actually used with a proper purpose and a proper use case. And at the time, he was referring to maternal mortality. And what you're speaking to was, pick a use case that can resonate with a country's felt problems together with the political direction. The question around data protection, regulations, and acts is a good one. It fits within the 7 building blocks that was in my presentation. If you looked at the presentation carefully, it was based on the premise that a country's national strategy is a basis for digital health interventions, including AI. And so such a strategy must include regulations, which is where data protection comes in. The other 6 pillars have to do with governance, financing, interoperability, and etc. So a number of countries have begun looking into the whole issue of putting in regulations for data protection. A case in example is Kenya, because we've worked with them very closely in the development of the digital health law. It's one of the few countries that put in place a digital health law in place. Then we recently worked with Namibia, where the country, in the pursuit of digitizing the health sector, worked with WHO to produce a digital health policy. So we're coming from simply having strategies to having specific targeted regulations that speak to specific use cases. And so data protection is key. And congratulations to Sierra Leone, because we have seen Sierra Leone undertake great progress in terms of strategies, as has been mentioned by the questioner. But data protection is key. And this ensures that the whole foundation of AI is the availability of data. Data access is one of the key enablers there. And so data protection is quite is a key enabler. So a number of countries, yes, are putting in specific regulations that extend the digital strategy to include data protection, as has been mentioned just now. Thanks so much, and back to you.
If I could just add to Derek, I mean, really important what you said from a governance point of view, but I'll just remind you, if data security was extra onerous, we would never have ChatGPT, DeepSeek, Claude, or any of the other models that are transforming your life today. So although intuitively we gravitate towards the importance of data security, and I'm in there, but I think we also should manage that in a responsible kind of way. And ultimately, to me, it's not the government, it's the individual that should determine whether they want their data to be used, not used, or whether they want to be remunerated for making their data available. So, it's a double-edged sword again. We are beneficiaries of all of these things because data is publicly available. So, are we going to put future generations at risk because we didn't want to make our data available? I think we just need to be more thoughtful and innovative, also from a point of view of data security goes.
And lastly, perhaps I'll just add one sentence, seeing that Dr. Precious Matsoso is back. The
Yes.
question also included there was a statistical dimension. So thanks so much, Professor Rabin. So in the African region, in 2023, the Regional Office for Africa conducted a rapid survey on the penetration of eHealth. And that 2023 survey noted that 35 African countries had enacted national data protection regulations. And from that particular count, 3 of them had gone ahead to put together digital health laws. That includes Kenya, and now Namibia is a newcomer. 17 had no law per se. So the point is that, as has been mentioned by different speakers, AI is data heavy. And so having regulations such as these ones ensure that there's a trust from the public. Thanks so much, and back to you, moderator.
Thank you. Excellent question, and thank you both for the discussion and answers around that question. And now I see Dr. Precious Matsuso is with us, and we would like to hear of your work, and particularly with regard to the regulatory process associated with artificial intelligence.
Yes, thank you. Thank you very much, and my apologies. I had a technical glitch. Thank you for inviting me, and it's good to see familiar faces, Ruben and Derek. And thank you for inviting me. I'll be very brief actually and just share some of the trends, but key issues, particularly in the regulatory spheres that are of importance, but those that relate to Africa, and taking a leaf from the developments, of course, in bigger regulatory agencies like FDA and the European Medicines Agency. As you can see that there aren't so many countries that have AI-related bills that were passed between the years 2016 and 2024. And it just shows that particularly in the African continent, that we are still lagging behind. A number of countries could have policies, but when it comes to legislation, I think we're still lagging behind. However, in relation to data protection and privacy, it's quite clear that a significant number of countries in the African region have laws that provides protection, data protection and privacy, and some of them are beginning to kind of use those pieces of legislation as a basis of navigating AI, even though there's absence of provisions that deal specifically with AI laws. But we've also seen an increase also in the use of regulatory submissions. So well-established regulatory agencies have been, so far they've been evaluating submissions that are AI related, and the FDA in particular, just between the years 2016 and 2024, have evaluated about 7 applications which span anything from oncology, gastroenterology, neurology, and so on.
1 hour
But
behind.
But the issue here is that for well-established regulatory agencies, it's much easier because of the capacity, the infrastructure, and so on. But for regulatory agencies in the African continent, we are seeing trends, and I would like to give a perspective. WHO has come up with a benchmarking exercise of assessing regulatory performance and operational capacity. And so far, out of the 54 countries, only 9 have reached a maturity level 3. But more recently, one authority has reached maturity level 4, which puts it in par with the FDAs of the world and EMA. So if you look at the AI across the drug product life cycle, you'll see that for each phase, the regulatory agencies are beginning to see AI related, data generated that is used for purposes of submission in the discovery phase, non-clinical research, in early clinical research and late stage, but also post approval, we're beginning to see these trends. But from a regulatory point of view, and in particular for those regulators that are in the region or those who are in resource constrained settings, because AI touches the entire regulatory life cycle, the FDA does engage pre-submission, where they get scientific input from applicants, from companies, industries. There's also dossier triage and submission and some means of validation. But they also conduct benefit risk assessment, and they do GMP inspection analytics, clinical trial data analysis, and so on. But at the same time, for those regulatory agencies that have constraints, they've begun now to introduce certain measures that can reduce the workload, but also help them navigate these regulatory life cycle AI generated data. So, but now there is some form of fragmentation because different divisions, even within the same regulatory agency, adopt different tools. And it is creating a bit of a concern for some regulatory agencies because if it's a division that deals with inspections, it means they will move ahead and have capacity at the risk of not bringing other divisions with them. But there's also inconsistent use, and I think it's across the whole region, but there's also over-reliance for some of the agencies without governance. But at the same time, there are benefits in that some have seen reduced dossier volumes, and particularly, MCAZ, they've actually begun to use AI, and it has helped them leapfrog actually from a certain level of maturity to ML4. So there are 3 key areas that I think are of relevance for the African continent, particularly for regulatory agencies. The first one is that most are beginning to use AI for pre-screening applications, and others are beginning to see its use in scientific review processes, but also based on reliance, because some rely on reports generated by well-established regulatory authorities like FDA, EMA. So they actually see that as a basis of support for reliance-based regulatory reviews. But there's also a significant potential for sameness reviews, in that when they screen some of the submissions, it's always important to see whether there are some similarities, particularly if there's reliance. But there's also an opportunity for reviewers to navigate complex scientific issues. But it's not only on the clinical side, but also on the quality aspects of the dossiers, for instance, the manufacturing and so on. The AI is helping them standardize electronic submissions and data exchange through key standards that have been developed, for instance, by the United States Pharmacopoeia or European Pharmacopoeia. So they are beginning to navigate these complex standards, and they are able to access data. But there are problems of fragmentation across the whole regulatory sphere. But there are also divergent risk classification systems and also governance gaps. Like, even though they have, countries have data protection laws, but at the regulatory level, there's still divergence in terms of application and also institutional capacity asymmetry. So one of the things that might help countries is to look at good AI practices. In that both FDA and EMA have come up with guiding principles that can help individual regulatory agencies to come up with their own practices that are of good standards. Like, for instance, practices that promote principles of human-centric designs, risk-based approaches, for instance, data governance and documentation, but also risk-based performance assessment and multidisciplinary expertise. So the risk-based regulatory framework that currently is a good model is that that has been developed by the FDA, which has 7-step processes, and it helps the regulators navigate some of the risks, but it also helps them define questions of interest. It also helps them identify the context of use when a dossier is submitted to them. It also helps them assess the risks, and it helps them also plan their way in the review process and prepare reports as these submissions are made. But there are, of course, ethical challenges for those of you who submit, applications for the conduct of trials. You'll know that there are certain ethical dimensions that apply in the regulatory environment. It's not just for ethics committees, but also the regulatory agencies do look at the ethical principles. And I think the ones that stand out, particularly for the regulatory work, are those that deal with privacy and confidentiality, trust and transparency, reliability and safety, but also bias, discrimination, and fairness. But the one that bothers me most is the one on dual use and security risks, where AI systems could be applied to develop harmful biological or pharmaceutical agents. So in conclusion, I think the trends show that there's an upward movement. And I think for the African continent, for the regulatory environment in particular, the regulators can actually leapfrog from doing heavy duty paperwork of evaluating huge volumes of data to just having simplified models of evaluation. And with the rapid growth in adoption, I think this can help them leapfrog and ensure that there are risk-based frameworks in place, particularly with the creation of AMA. We'll see harmonization that is currently underway amongst regulators. It will also help them with the exchange of data, sharing of reports, but also it will also help with transparency and documentation. But it shouldn't take away human oversight. And it also requires that there should be a good practice models and governance. I'll stop there. Thank you.
Thank you. Thank you very much. Because you covered both of the questions that we had for you, regulatory and also ethics. Perhaps if there is some time at the very end, and we're reaching the end, I think, in terms of our time availability, uh, we could kind of get your last thoughts about fragmentation and what you would look toward in the future in terms of collaboration with some of the activities that are going on with the various member states. I would like to go back to Professor Youthman at this point for a question regarding his presentation and subsequently the work that he is doing. How can African countries build the capacity to harness AI sustainability and equability for their most pressing health challenges, particularly in resource limited settings?
Thank you, Dr. Morgan. And so in terms of building capacity, I mean, so I will sort of try to discuss it under 4 points. I know we are sort of almost we're out of time now. So in terms of capacity building, I mean, it should not just mean how to teach people to use AI, but we need to build people and not projects. So we should not measure capacity by how many people attended the workshop like this or how many people can use AI, but we should measure how African institution can assemble and retrain capacity in terms of taking solutions from health problem to development, validation, implementation, and evaluation. So right from engineering, medical school, health economics, and trialists. Then second, we need to build data and digital infrastructure. So, I mean, the AI cannot solve the fragmented problem that we have in terms of health system now. So we need to build infrastructure to be able to collect data and digital transformation. Then thirdly, we need to build institutional and governance capacity. I mean, a lot have been said about this. So we need to be able to know when it's safe to use a model, not just importing a model from another region. Then lastly, in terms of the model of partnership, it's not just someone bringing a pilot study, but after the pilot study, what did you leave behind? Can people actually do the model themselves and implement it? So that's in terms of capacity, not just looking at how many people we are trained, but can the African institutions take ownership of this AI delivery, right from identifying the health problem, evaluating and developing it. So that's how I would say in terms of how we can take this forward. Thank you.
Thank you very much. And I think that we are nearing our time for our panel. And we've had wonderful presentations today and also discussion, particularly the first question that we had that I think included Dr. Pillay as well as one of the respondents. Many challenges before us in terms of understanding what the challenges are today, but clearly, I think the framework that WHO has provided today is going to give us the opportunity to see continued progress on the continent of Africa and places for all of us to participate as we increase the incorporation of AI in public health and public health surveillance of disease. With that, Dr. Brown, I will turn over our stage to the next panel, and thank you very much for allowing us to participate.
Thank you very much for a dynamic panel. I would say there's sort of one question that's left for them to think about as we move to our second panel is trying to develop a culture of cyber hygiene, ethical scholarship, and support for trust in digital health. And that is something that I think, as we are looking at collaborating, very important for us to think about as we're building these new systems and recognizing, as I've seen in one of the questions, also what is the political process within all of this that should be considered? I know that this panel is over and we have a brief break. I would ask, as the second panel is planning to come up, to please, because I'm seeing hands are being raised in our chat box, we ask that you put your questions in the Q&A. And we will certainly try to answer them. Things that are in the chat box, we will have that information and can archive it. And we're trying to explore the question that continues to arise about a certificate for those that are in attendance. We will answer that online. Thank you all again for a dynamic panel. And we will move to our second panel. And as they are preparing, that will be moderated by Professor Malinga and Dr. Rajib Eswari as you're getting prepared to come forward. But I would ask for us to just stand up and do a little movement in place. If you are sitting for a long period of time, we want to watch out for your physical health as well as your educational health. And if you will do that, thank you all very much. And continue to list your questions in the Q&A. We will either answer them online or we will respond to you appropriately. Thank you. It's probably a 2-minute break now. Dr. Rajib, you're coming up for the next panel.
Dr. Rajiv and Professor Modis, you're on deck.
Hello, can you get me?
Yes, sir. We're ready to go with you and your panel.
Yes, thank you very much. I'm just waiting for Dr. Rajiv to start the session.
Hello. Good day, good morning, good afternoon, good evening, colleagues. I'm Dr. Rajiv Rao Ishwari. I'm moderating along with Prof. Modest Mulunga. Professor Modest Mulunga is a Vice Dean of Lusaka University, and we have three panelists. One is Mr. Dr. Neeraj Mistry. He is the he is a health economist and he's been practicing integrated medicine. And we have Mr. Stephen Vaney. He is the vice chair of Africa Digital Health Network, and he was the immediate past president of Helena, Health Informatics Association of Africa. And we have Dr. Moses. He's the CEO of a IT company based in Nigeria. Without much ado, I'd like Prof. Modest to start with the first question.
Thank you very much, Dr. Rajiv, for that generous introduction. And I just want to thank the panelists for making their time to be here with us to discuss this important but vexing topic. I do take cognizance of the fact that the keynote speakers set the ball rolling for us to understand where AI sits. But the most important thing is the financing for AI. Dr. Yeni mentioned the issue of that we faced before when African countries commit funding to healthcare, but in essence, that doesn't come to fruition. Health research is the same issue. Right now, we are facing significant geopolitical changes that are making a paradigm shift in the financing of various sectors of health, including various sectors of human endeavors, including health, where the traditional ways of funding are shifting because of the changing geopolitical situation. Now, for Africa, we face many challenges, not just health. Africa faces major competing health priorities. Now, the question to my panel is, why is now the right time to invest in AI infrastructure for healthcare, and what should that infrastructure include beyond the computing and data centers? Thank you.
Prof, would you like me to start?
Sure.
Okay. Excellent. And I'm delighted and honored to be on this panel with such esteemed colleagues as well. So I just wanted to reflect on something before I dive into that question, which is in health and well-being, we've gone through quite a few technology introductions and inflection points. And I think many of us can remember eHealth and moving from analog to digital and mHealth. And these were all huge promises that we experienced that were going to be transformative for health across Africa and across the world. And so AI particularly feels like we are at yet another inflection point. Somehow, though, this feels a bit different. This feels a bit different because AI is not just a technology, as in computers and infrastructure in that way. AI has very significant impact and influence on content. which when we look at other forms of connectivity, storage, etc., those were all tools that we used, but it didn't influence content. And here we have a difference now where it's influencing content. So I think that's one of the differences that we have now with an inflection point on the introduction of technology. Which comes to the question then, why now? Well, I think when we look at the African context, with every inflection point and introduction of a technological intervention, we have to keep up with peers around the world in order for us to be relevant, in order for us to play at that same level, and especially when we're starting to see the impact that these tools have had in terms of efficiency, access, better delivery of care, etc. So I think the timing is right now for us to start thinking about this in very serious ways because of the potential impact that it has. And so when I do think about the investment of it, and I want to use another interesting analogy, at some point in all our global health programs, we said, oh my God, monitoring and evaluation is important. We have to be able to measure what we're doing and show the impact of it. And so before, monitoring and evaluation was an add-on that we did to programs until we realized how important it was. And we had to put in a budget line item for M&E in everything we did, in every program. And I think it's pretty much the same way we need to think about it. When we talk about administrative costs, costs related to equipment and computing and medical devices, we have to think about costs related to content that's AI related. So I would say that in every program, we need to budget a line item now for AI related interventions. And so I think that's on the budgeting side that we need to think about it and embed it in everything that we do. So let me stop there and hand over to colleagues.
Thank you for those insights. We'd like to hear other contributions from other colleagues on the panel.
And thank you, Professor Modest. So this is Stephen. Sorry, suffered a little bit of connectivity outage here, so I'll keep my video off for now until I get better connectivity, and I'll connect. I mean, I think just joining what Dr. Mistry has mentioned, really just not to belabor his point, but just to, I think, extend that contribution that I think one of the things that we need to invest a lot more, in my strong opinion, and I think it's an opinion that is also shared by a couple of other colleagues, particularly in the global digital health community. I think it's this, as Dr. Mistry has mentioned, I think it's this notion of public health and clinical content, particularly the work that is done by international organizations, that are fairly authoritative in nature, in normative guideline development organizations like WHO, that are there to, one of their core businesses to produce clinical and public health guidance that then we know AI is increasingly using a lot to approximate. But then I think the point I'm trying to make here is that with the work being done by WHO and others in the global health community, would be to invest a lot more in transforming those into more structured and executable and also verifiable knowledge assets that basically any AI system can use to reliably produce a lot more deterministic like results. And therefore, this means that because the mechanism is already established, for years and years, WHO has been a trusted authority developing those clinical public health and data guidelines that then its member states in 194 then customized to their context. And that system works pretty well. And we all know that that's also reasonably well informed by clinical trials and evidence, so that good care reaches the persons who need it most in any of those member states that subscribe to that mechanism. So I think leveraging on that mechanism that has worked very well and is trusted is really then to move, particularly the content, I think, as Dr. Mistry has mentioned, given what AI needs, so that we reduce the approximation and get a lot more deterministic And it's possible now with the way the technology has evolved. The advancement of skills, whether it's data science skills and all that, we can do this a lot better. And I think what that really helps is that one, you also continue standardizing care, but also ensuring that care is also adaptive to the context, again, based on that mechanism that's already been well adapted and formally established across the world. But I think also beyond clinical public health care, this can also inform procurement and regulation as well, because then we are moving a lot more to operational or applied standards, and not just the PDFs that sit on shelves and all that, we've got all this wealth of scientific knowledge that has moved from trials to policy to adaptation by member states, but there's still a gap because AI can't access it. But we've now got the tools that are fairly advanced, and everything else, including computing, I think, as Prof. you mentioned earlier, that we can use a lot better to really make this content, again, more structured, executable, and verifiable for AI purposes. And like I said, that also informs procurement, that member states, based on the limited resources they have and all that, are able to actually make the right procurement decisions. It also helps to inform regulation, which is an ongoing area that everyone is sort of grappling with, whether it's based on the, sometimes on conflicting evaluation benchmarks and all that exist currently. And those can, that can be helped to guide and support member states, to ensure that they're evaluating that against published standards. So then what that means is that even the global health community is able to coalesce a lot better on established mechanisms, WHO included, where, for example, they become more authoritative, particularly as WHO, which I think continues to have a major role in healthcare and digital health particularly. And they continue establishing and consolidating the authority as a source of AI-ready clinical knowledge for global health. And then the mechanisms by which that AI-ready clinical knowledge reaches the health workers, patients, and systems everywhere, then is a more of a technology effort, which nowadays it's really very low effort and not as expensive. So technically there are many approaches to do that. There are people who are, many people who are discussing that, part of a group that is seriously discussing this aspect and hopefully moving that into more production-ready implementation. But I think that's one area that certainly Africa should not be left behind. Thank you, and back to you, Prof.
Thank you very much. We still can have some inputs from Dr. Moses, if you're there.
Yeah, I'm right here. Thank you very, very much, Professor Modest. I think my colleagues have done great justice to this conversation, basically. And for me, I'm going to approach this conversation from a perspective of numbers, of statistics, basically. And I think I'll start with the population in general. The population of Africa is approximately 1.58 billion people. And sub-Saharan Africa basically carries 25% of the world's disease burden. And, but we only have 3% of the global health workforce. And if you look at it from that perspective, we would also need to consider how WHO sees it. I believe that was the end of last year. There was a revision to its projected, projected shortage in terms of health workers in Africa. So approximately 5.85 million people health workers by 2030. If you look at that in perspective, 5.85 million health workers to over 1.58 billion people, that's approximately one doctor to over 270 people. And that just shows you how catastrophic that is. And last year alone, over 940,000 trained healthcare workers were sitting at home unemployed with, and we still have patients that needed care, basically that they couldn't attend to. And I'm talking about trained healthcare workers. But what this thing speaks to is not just an accident. It's a financing gap. And if you want to understand exactly the reason behind this finance gap, we would go back to 2001 when 54 countries had an agreement and then said, you know what, at least 15% of our national budget must go into healthcare. But I mean, 25 years later, right now, we only have approximately just 2 countries that have actually hit that mark. And we were talking about 15% minimum of the budget. That's minimum of the budget should be 15%. And, you know, if this is not a choice between, you know, between AI and immunization or maternal health or some other things I might want to bring up, it's more like AI infrastructure is how we make the workforce we have go further right now while we fix the deeper financing problem underneath it. If we want to look at it from a more practical perspective, in Kenya, for example, I think Penda Health ran a clinical co-pilot with OpenAI at some point, and they worked with over 40,000 in-visits, real patient visit, right? And the results are there. The results speaks for themselves, right? Which is, you know, they cut down diagnostic errors by over 16%, and also cut down treatment errors by over 13%. Now, if you scale this, if you put this on scale, you realize that that's tens of thousands of avoidable errors per year. And, you know, we're looking at facilities whereby, you know, patients pay approximately maybe $90 per year for healthcare, as opposed to, or in contrast to over $14,000, $15,000, $20,000 in places like the US, right? Now that just shows more, that just goes to buttress the fact that the environment that this technology has to prove itself in is in low margin, high volume, understaffed environment like ours. This is an environment that we find ourselves on a day-to-day. Majority of people on this call will be able to relate to that, as they live in Africa. It's basically our reality. Now, if you look at it as well from another perspective, we would say, you know, the median age in Africa is approximately 19.5 years. 60% of the population are under 25, and then they're mobile first. So basically, if there was really any time, like Dr. Mystery said earlier, if there was really any time for us to be considering, you know, upscaling AI and, you know, introducing it into our environment, it's right now. Because, I mean, we cannot keep trying to retrofit, you know, legacy systems, the old archaic systems and trying to make it work now. And if Africa in general, if we do not take the step to improve from an AI perspective, we'll find ourselves again repeating these same things in years to come, wherein we're importing technology that is native to other places, not native to Africa, basically, and trying to also still make it work, right? In this same setting, basically, we are importing systems built for someone else's diseases and someone else's languages. But basically, if you want to look at it from a much broader perspective as well, infrastructure behind compute, because it's one of the questions that Professor Modest asked earlier, right? Infrastructure beyond compute and data center has to include a couple of things. In my own opinion, I would say it has to include power, right? Because, I mean, if you look at it, most of the data centers combined in Africa spend or have if you add the 5 biggest markets today, basically, we'll say they spend under 500 megawatts, which is basically less than France alone, right? Now, but power on a facility level, it's one of the major things that we need to look at. And we're not even talking about data yet, right? The next part of this now would be, you know, African-owned data and locally trained algorithms. Now, several companies, several tech companies are trying to make this work. Several individuals, several school of thoughts are also trying to make this work, right? Basically, these models, so that our models can reflect, you know, diseases that are, you know, that are right here in Africa, localized to Africa, you know, with established patterns, right, across Africa, not imported and trying to get fitted to our own system. Establish our patterns across Africa, right, and also languages that are also our own. The third part for me would be interoperable digital health record system. Now, as we already know, majority of the countries across Africa are paper-based, right? And, you know, every country right now is trying to go digital, right? Without that data, the AI cannot be fed. Basically, the data feeds AI, and AI improves with the data that comes in, right? The fourth part for me will be a good governance framework. I think several of my colleagues over the course of this presentation have spoken about that, right? I think Africa CDC's continental health data governance framework, has been is playing quite the role when it comes to that. I mean, this helps sovereignty to scale and not just serve as an extraction. So in my own point, I mean, to just in summary, right? AI is important now, right? And we need to work together to make this work. Thank you
very much. Thank you very much, Dr. Moses, for those insights. As you can see, the topics that are coming through kind of sweet to continue the discussions. Unfortunately, time is not with us. So I'll proceed to hand over to Dr. Rajiv to continue the discussions. Thank you.
Thank you, Prof. The next question is about financing AI infrastructure for sustainable scale. The first one is, it's a bit loaded, but let me start now. What funding models and partnerships will best help Africa build and maintain the AI infrastructure needed for sustainable scale? That's the first part of it. Can we have the panelists? Who wants to start first?
Oh, in the interest of time, I'm happy to dive in.
Yeah, sure.
Dr. Al, I think you've addressed it properly, where you talked about a multiplicity of things, and I think that's the first thing we need to be clear on. There's going to be several financing models, and they're going to finance different aspects of things. And I want to build on the infrastructure point, because I think we can think about financing in different ways for different parts of the infrastructure. And I want to start off by AI governance. And I'm using that broad term governance that protects patients, confidentiality, regulates, etc. And I think it's redundant for every country to establish that governance on their own. We need to look and think about Africa collectively as a bloc. We can do it sub-regionally, whether SADC, ECOWAS, or EAC, etc. Or we could look at it as a continent as a whole, leveraging the sort of regional bodies that we have. So the Africa CDC, WHO Afro, etc. We can use that to help develop policy around AI governance. And I do think what's important for that is it needs to be interministerial. So this doesn't sit just with a Department of Science and Technology, but also departments of health, family welfare, etc. And I'm sure the heavy industry departments and minerals extractives are also dealing with these sorts of AI-related issues. But particularly from a health point of view, we need interministerial action. We need regional collaboration that sort of sets the tone for the region. So that's on AI governance. The other two areas is AI utilization and then AI generation. I want to call it. These are those data centers. So utilization, thinking about how we make access for our doctors, nurses, etc., much easier. And that needs to be financed. What is the infrastructure requirements, whether it's computers, whether they have access to fora where they can deliberate these issues, put in data, etc. And I think across Africa, there's no one size fits all, because we have public sectors, we have private sectors, there are market-based mechanisms, there are public financing mechanisms. So depending on the country and depending on the cohort we're dealing with, I think the financing needs to be put in as a line item in each of those areas on AI utilization. And then the last point about AI generation, and this is a really, really interesting point, because can we think about AI generation as a self-financing mechanism? And here's where I'm going with this. So yes, we know all these data farms and centers that are being set up, and the electricity costs are huge. Water utilization is huge as well, although it's not as big as it's made out to be, but the electricity costs are very big. Now, there's a colleague of mine from Kenya who talks about something we have in Africa that is something we should commoditize. Interesting. It's called latitude. We have latitude, right? and latitude literally with our location geospatially. And because of our latitude, we get sun like no other places in the world. And can we leverage that for solar power generation that can power these data farms? And so we can think through a business model for AI that many places around the world are shying away from because of environmental impact. So with a good regulatory framework, can we think about Africa as a location that becomes a business opportunity for these AI data centers? And I think we need to be really, really creative. It requires leadership to sort of steward this process in, but I think it's something we need to think about in a longer term sustainability, not just covering the costs, but generating revenue for the continent. So let me stop there, but I think there's huge opportunity for us to think creatively.
Thanks, Dr. Mistry. Steve or Dr. Moses?
I think I could just weigh in real quick, right?
Yeah.
From my own perspective, I mean, we've had several different meetings with top companies trying to understand exactly how several AI projects could be funded. And, it's always very interesting to see exactly, their reactions to several things that are brought up during these meetings. But I mean, so as not to waste any time, I think I'm gonna define my own perspective I'll say in the quadruple helix. I think Dr. Mistry has said something pretty much interesting, which is these things need to be looked at as more of a budget line, not just we saying, hey, let's get someone to finance one thing in AI. But if we look at it from a quadruple helix, we'd say we have the government, right? We have development finance institutions, we have private sector and tech industry leaders, and I would say we have philanthropy. So if you look at these four different sectors, right? If we piggyback again and say, okay, fine, one of the major issues that we've seen often would be governments shying away from having that 15% put into the budget for health, right? And it's not because they cannot do it, it's because they will not do it, right? But if we look at it from that perspective alone, now we can say things that have to do with data governance, that have to do with licensing, that's to do with real budget line for digitizing primary care records, for example, because again, that's the fuel that AI runs on, and no outsider will want to pay for unglamorous work, right? So again, the government should be heavily involved in that, right? Because again, this directly concerns its citizens. But now, if we look at things that now have to do with, I'll give you an example. There is an initiative by the African Development Bank and the UNDP, which is more like a $10 billion initiative launched in Nairobi I think around February this year. And the aim is to mobilize $10 billion in human capital, in compute skills, in trust, and basically around data. Right now, we now understand the role that development finance institutions can play if they work hand in hand with government agencies. Now, if you add the private sector into this, right, this is more for the build and operate tier of this helix, right? We will then understand that as opposed to we having private sector industries, sort of kind of sign different bilaterals with several different countries, 54 different bilaterals, for example, with 54 different countries. We could have something more regional, something revolving around a more regional infrastructure, so much so that we don't have to repeat the cycle over and over again. The last part to this would be the philanthropy aspect, or the de-risking tier, in my own opinion, which would be using philanthropy to fund pilots, open local language models, proof of concept. If you put all of this together, I believe we could get a very, very interesting funding vehicle that could, push forward AI adaptation across Africa real quick. Thank you.
Thank you, Dr. Moses. Mr. Veni? Mr. Veni, are you on? Looks like some issues there. Maybe a follow-up question quickly to the panelists. What financing options and incentives can help local innovators and health organizations build and grow AI infrastructure across Africa? Make it brief. Let us start with Neeraj.
So I think that starts off with creating the platforms, the communities where people can operate. So I think we don't have the luxury of market-based mechanisms where all of these things happen in parallel. So we need to start thinking about incubators and accelerators where young entrepreneurs, developers, etc., can go and they can get support. Because when there's an entity, then that can be financed. It has the infrastructure and support for people to move forward their innovative ideas and creations. So I would say that we should definitely look at that model of incubators and accelerators.
Yeah. Thank you, Dr. Mistry. Dr. Moses?
Just to add to what Dr. Mistry said, I think beyond incubators and accelerators as well, if we look towards a more regional compute, like I said, like we already understand that the resources needed to push AI from where it currently is to where we expect it to be, they're huge, right? So again, if you look to more pooled regional systems, right? Basically, no single African country needs to build his on his own. If my neighbor and I can build together, right, it reduces that computing, it reduces that environmental impact that we're trying to avoid. The last part would be, also workforce, basically, as opposed to just training medical doctors, right, or healthcare practitioners, also giving them that digital training, basically. So it goes hand in hand. It was one of the first things that was said when Dr. Rubin was doing his own presentation as well, right? All of these things work hand in hand. If the workforce is already trained digitally, it will be easy for them to be able to roll into adapting these things real quick. Thank you.
Thank you, Dr. Moses. Mr. Veni, are you on? Mr. Stephen Veni? Looks like he has got network issues. Professor, back to you. Prof. Modest, back to you for the next question.
Thank you very much for those insights that we've had. My next question really is to try and just condense some of the responses that we've heard from the panelists to do with building sustainable AI-enabled health systems. So to that effect, my question will seek answers that are very straight to the question, what strategic investments are needed to move beyond isolated AI projects and build sustainable, scalable, and locally relevant AI-enabled health systems across Africa? Dr. Mistry.
Prof, that's a big question. That's a dissertation question right there. So as I thought about this, there's a few things that come to mind. And I think what every country needs to do is some sort of needs assessment, right? What their health needs are. Now, as I think about that needs assessment, because very often when we think about systems, it's about how do we put in something big at scale that's going to cover everything. And it undermines a lot of work that's been happening for decades that has had very positive results. When I was teaching global health, I used to ask my students, so how do you think we're doing in health? And, oh, we're bad, people are dying, everything. And I'm like, no, we're doing phenomenally. When we look at maternal mortality, infant mortality, we've made tremendous progress with different interventions over time. So there's a lot to build on. And thinking systemically doesn't mean plonking down something new because it's nice and shiny, but it's about a deep assessment of what do we have and what is the problem we want to solve. And so problem-oriented AI integration, I think, is the way we enhance the systems at play and build the AI system around the current infrastructure that we have. And as I thought about needs assessment, I think for our countries and with subnationally, because our private systems in some countries compared to the public systems are quite far apart. And so you're addressing different types of health systems within a country. But the needs assessment, I would say, has to have three categories. One is critical. We need this sort of intervention tomorrow. How can AI help us for that? The second, I would say, is about efficiency. So we're doing things, we're doing it well, but how can we do it better? And how can we do it that saves us money and is more cost effective? And the third category I would add is nice to have. So it's not mission critical. It's not going to improve efficiency, but it's nice to have. It's going to tell us stuff. It's going to be interesting, type of thing. And a lot of research, you look at it and you're like, that's interesting, has no implications or applications in life or in programs. So I think it's important for us to start thinking much more in a much more nuanced way about AI, what's critical, what can improve efficiency, and what is nice to have, and link those to those gaps or hotspots that we have in countries. And so let me stop there. There's a lot more I could add to that, but I want to give my colleague some bandwidth on this.
Oh, thank you, Dr. Mystery. I think you've whatever I would have liked to say, I think you've said it already, right? But just to add a little bit more, if we talk about the word scalable,
please, if you have slides, please feel free to add them. You've got a bit of time to do that. Thank you.
No worries, right? If we talk about scalable, if we talk about long term, right? If we talk about sustainable, those are huge words, right? And one thing that you might need to add to that as well would be affordable, right? Because again, in this part of the world, right, we could build several different systems, and a lot of systems that exist in silos, right? They just get created, several pilots get run. There is really nothing getting used after the pilot is done, and then somebody comes again and does the same thing, probably adds a little bit of this and that into it, then everything changes. But we cannot continue this repetitive cycle, right? But in order for us to be able to break that cycle from what currently exists and then scaling up into something that we are trying to call sustainable, it simply means now that, as Dr. Mystery said, we should solve problems that are identical to us, right? Not trying to solve the whole problems when it comes to healthcare. It's taking the African healthcare problem and then fixing it, right? We take one thing, if we can say healthcare access, for example, and healthcare access, is one problem. Go to rural areas, they would never have access to some things that people in more urban areas might have, and this would scale over different countries, right? It's basically, the answer to this is basically going to a granular level, picking out exactly what is identical to whatever situation we find ourselves or whatever locality we find ourselves, and then looking for answers from an AI perspective to solve that particular issue. I believe if we can go from the part, then that interoperability would come, because now some other thing will rely on what just created right now to be able to improve itself. And if we continue in that particular direction, I think in some years to come, the sky is the starting point, basically.
Thank you very much. Do we have Dr. Moses around?
No, we're looking for Mr. Stephen Venny. Is he around?
Oh.
Dr. Moses has.
Oh, yes,
yes.
indeed.
Thanks,
Yes.
Rob. Yeah.
Mr. Stephen Venny, are you still there?
I think he's having some technical difficulties. I don't see him in the participant corner.
Okay. Yeah, in that case, since we have a minute or so, any of the panelists can emphasize the point that they wanted before I hand over to Dr. Rajiv again. If not, Dr. Rajiv, please continue the discussions. Thank you.
Thank you, Prof. The next question, the esteemed panelists, is on a 5-year impact and commitments for AI-enabled healthcare. Over the next 5 years, what change from your work will you most improve AI-enabled healthcare in Africa? And what should governments, development partners, and private sector commit to doing within the next 12 months?
Moses, I'm going to let you start on this one.
Okay. Within the next 12 months, I would say I would want 3 concrete checkable commitments, not pledges, from governments, for example, a named budget line for digitizing primary care records. This is the fuel through which any AI system can function. And formal accession to the continental health data governance framework, not just political support for it. That's from a government's perspective. From development partners and DFIs, basically, I would say disburse. Don't just announce. The first tranche of catalytic capital from the AI 10 billion initiative specifically into health with published terms so we can hold them accountable at next year's panel, for example. From the private sector and tech industry, I would say publish outcomes. The way OpenAI and Panda Health did it, 16 fewer diagnostic errors, 13% fewer treatment errors across nearly 40,000 real patient visits. Because evidence like this is what unlocks government and donor confidence at scale. And this is one thing that's heavily missing, right? And we should commit to building shared local compute capacity rather than just API access alone. And in 5 years, basically, if we come back in 5 years and all we've done is run 40 more pilots or 50 more pilots or 1,000 more pilots, I would say we've failed, right? The measure of success is whether one financing decision made this year, pooled, sovereign, accountable, for example, is still standing and scaling at 2031, right? So again, in my own opinion, I believe it's not just about, repeating the same things over and over and, trying to make things look a little bit more glamorous. It's about making one financial decision and then, we're making that scalable, that quantifiable change over the next couple of years. That change that, speaks to one particular issue that we've chosen to fix with artificial intelligence. Thank you.
Dr. Mistry?
Moses, that was lovely. So I would like to see 3 things in the next 5 years as things unfold. So the first, I think, that's critically important is governance. And we use this term so often. And at one AI conference I was at, the person who spoke on governance said, okay, we're all going to chew cardboard together because that's what it feels like when we talk about governance. But let me give you an example of this. I was asked to help intervene in questionable hospital admission on behalf of a family friend. This was an elderly gentleman who went to a hospital here in Johannesburg, and his attending physician said, I think this man needs to be admitted so we can run tests and we can monitor him very closely, and that was his decision. This was then referred to the admissions person who was employed by the health insurance company. And the health insurance company had given this admissions person an algorithm, an AI algorithm that was telling them this person didn't need admission. So the doctor then went and started getting AI-generated clinical evidence on why this person needed admission, and they were at loggerheads. In the meantime, the family, who I was representing, was scrambling to find online tools that they could use at home to care for their elderly family member. And so here's a wonderful example of how we have a situation where 3 different parties, the payer from the insurance, the provider, and the patient, were all using AI tools to try and optimize or come to a solution on the management of this patient. And based on their relative perspectives, the use of AI was biased in their interpretation in order to achieve a particular outcome. And so this is where I think the governance structures, which need to be multi-sectoral and transdisciplinary or multidisciplinary, that needs to be made up with representatives from civil society, from the private sector, from technology, from healthcare, from government, etc., that we can deliberate these governance structures importantly, and these are new type of governance structures we need to think through on overseeing AI in countries. So that's one. My second wish is not in 5 years, but in the next year or two, that there are national digital health assessments or audits. And every country's assessment or audit is going to be different. They're going to identify gaps based on their burden of disease, their needs, their existing infrastructure, systems in place. And those audits are then going to say, here's what this country's priorities are. So we don't have to throw everything in the kitchen sink at it from a technology point of view, but we can cherry pick based on those local contexts. And then my last wish, and I love this pyramid that we have. And the bottom rung of the pyramid is data. The next one is information. The third one is knowledge. And at the top of the pyramid is wisdom. And when you look at your medical careers, etc., over the years, it took such a long time to do the analysis, get the information, the knowledge to get to the point of wisdom and insight into patient care and management. And I would love to see how AI can help us accelerate on that curve toward wisdom and how we use those outcomes for the betterment of health and in society. So big wishes.
Thank you, Dr. Missy. Let us take chance again. Mr. Veni, are you still around? Are you still online?
Hi, Dr. Rajiv. I'm sorry, I've just managed to rejoin again. I dropped off for a while.
Okay. Okay, so did you hear the last question?
No, I did not.
Okay, so it's actually about 5-year impact and commitments for AI-enabled healthcare. And over the next 5 years, what change from your work will most improve AI-enabled healthcare in Africa? That is one. And in 5 years' time, what action will you take to help make it happen?
All right, thank you, Dr. Rajiv. I think from the work that I do currently, what I think might hopefully impact positively in the next 5 years, I think I would say is the work that I'm doing quite a lot on standards and interoperability. I strongly believe that and I think this is it's probably a fact. I'm hoping it's a fact that most of us share about AI is only as also as intelligent, obviously, what it interacts with. So thinking about modern science and how that's represented, whether it's through data, how that data is modeled, but more importantly, the meaning inside those data. And so hence to my earlier point before I dropped off, that I was talking about health knowledge and health intelligence, coming out of established science, but I think also indigenous knowledge as well. So I'm a strong proponent of intelligence. Is much as, of course, most of us are educated in the Western education systems and all that. I think we have over a long time also acknowledged that there's a lot of indigenous knowledge that maybe now it's easy to harvest and mine it, and that can be codified and really help to inform AI. And I think there's a bunch of people who are working on whether it's Ubuntu Health AI, thinking about how do we harvest and harness all that for use. So I think, Dr. Rajiv, for me, that's really where I think I would contribute to, and hopefully I'll be able to impact a lot in the next 5 years. Thank you.
Thank you very much, Mr. Beni. Prof. Modest, back to you.
Thank you very much, Dr. Rajiv, and thank you very much for the panelists. We've had very important points that have been raised. Just to cap it all, from the start of our discussion, we talked about how important is it for us to really start thinking seriously about serious financing models for artificial intelligence. And we also tackled the issues of the financing models that are appropriate for the local context. And that was explained very, very clearly. And I know that time isn't enough to actually tackle all of them in sequence. But we also had wanted to hear more about the sustainable AI systems that are relevant to local situations. That was heavily discussed. And those are the same points that were actually emphasized, that we need to focus on what is doable. We shouldn't forget about things that work for us. Build on those as we build something that we think is sustainable. But contextualizing the systems of AI was emphasized as very important. And again, we heard about the future perspectives on AI, which can be varied. And I know that in the time constraints we have in this discussion, not all of them can be tackled. But we heard from the discussants that at the moment, looking at what works and what doesn't is very, very important for us as we look into the future. And again, the panelists also emphasize the fact that we shouldn't forget the relevance of AI to tackle local problems and problems that are very key to sustaining health in different communities. And at the same time, making those systems, AI systems, accessible to the communities that actually need them. I think we've come to the end of our discussion, unless Dr. Rajiv, you've got a point also to add to the discussion. Thank you very much.
Thanks, Prof. I don't have anything to ask. You have covered it very well. Thank you, Prof. And I thank all the panelists for the contribution. Thank you very much.
Thank you.
Thank you.
Thanks all.
Thank you so much for this very informative panel. And I would just like to ask one question before you all get off and we take our next break. Given that we have a large system, and we talked about the business model that needs to be developed in terms of our data sets and data centers that will provide us with some sustainability. But I guess my question refers to how can this be developed with some interoperability? Because given many countries, there's not a universal system for the continent. And so within each country, there may be interoperability, but how can it be for those mobile personnel that may traverse various countries on the continent should be able to utilize that data without recreating the wheel? Is that too much to ask? And then how will that be financed? So back to Dr. Rajiv, Modest. Yes.
Dr. Mistry, would like to tackle that very briefly?
Yeah, once again, a big question. So I think we have precedent for that sort of mobility and access, and that's from mobile telephony, right? And people are, I mean, few and far between you'd see a Nigerian with just one mobile phone, right? It's one for each network, or like two or three, right? And so there's some countries that didn't get the interoperability right with different mobile networks, and some countries that did. And some could get it right, but chose to keep them separate for financial reasons, etc. But I think that's an interesting analogy or precedent that we have on how access to a network can be retained or promoted with mobility across different networks. And that I think would still apply, would apply in a similar way to different data sites.
Thank you very much.
Are there other comments to that? If not, I think we're at a breaking point. If there are no additional comments, again, thank that very interesting panelist. And again, I don't know and have not received word that people are still raising their hands in the chat box, but we want to indicate that we cannot recognize those hands, but if you had a question, to please go to the Q&A box to put your question in, or to give information about where you're from in the chat box. Thank you. We're going to have a 3-minute break. Again, we want you to stand up and shake those legs and raise those knees to make sure that we are being healthy from our wellness standpoint, and we will prepare for our third panel. Thank you all. Great. Are we getting the slides prepared for the third panel? It's going to be moderated by Mr. Malcolm Claiborne, talking about language.
Hey, Dr. Brown, we
Hi,
don't have
how
any
you
slides.
doing?
No
Your
slides for my
panel's
panel.
already there. Do we have slides for anyone that needs to be uploaded?
No, ma'am, no slides for us.
Great. Okay, we have a couple of minutes before we get started, about 5 after, if you don't mind. I think Josie usually put a clock up to tell us where we are. And I didn't see all your panelists are really already signed in. Thank you very much. There's lots of interesting questions for our panelists, as well as the hostess within the Q&A. And if you look at any of those questions in the Q&A and would like to answer them online, please do so. Or if you'd like to answer it live, please let us know and we will remove it from the Q&A box. And like you, Malcolm, I'm going to get some water.
I also took your recommendation to get up and stretch my knees. So I did that before I
That's
came on
very
camera.
important.
Okay.
So they have the educational trust where they
Okay, we'd like to welcome everyone back for our third panel. We're going to speak about natural language processing. We're going to talk about community agency and health communication. Our moderator for this section is Mr. Malcolm Clyburn, and he will introduce his panel and also say a few words about his background as well. Malcolm, you're on.
Hello, everybody. My name is Malcolm Clyburn. I am a health policy expert from the US and an advisory member of IME and a contributor to the digital health platform known as MedTech IQ. What we want to do for this panel is to kind of step away a little bit from some of the more clinical and biomedical applications of AI towards the models themselves, one, and two, some of the common interactions that a lot of the patients and communities that will interact with AI on the continent will have with them, which is through language. Dr. Pillay, during the keynote, used the phrase, I am wholly stealing Dr. Pillay, I apologize, that prosumer idea, right? Of a patient who is not only a consumer of health, but who is proactively managing their health, right? That agency is really important. But I think it's important to also talk about both sides of that coin, right? The possibility for greater health literacy, but also the possibility for greater health misinformation. And that ties directly into this concept of language and natural language processing. So on our current panel, we have experts in natural language processing, digital health, health literacy, and community health. And they could talk a lot more about the applicability of frontline models that we have and the risk and reward for deployment of these models on the continent. Sorry, one thing I did not do was open up my bios. So give me 1 second. I'm going to switch screens real quick. So for our introductions, and as I'm giving the introductions, the different speakers can come on to camera if they're not already so. We have first Professor Vukasi Maravati. Professor Maravati is a professor of computer science and the ABSA Up Chair of Data Science at the University of Pretoria, where he directs the African Institute for Data Science and Artificial Intelligence. He is a co-founder of LEPA AI and Masakani Research Movement and a leading voice in African language and AI and data sovereignty. In 2026, he was appointed to the UN's first independent international scientific panel on AI. Welcome, Professor Maravati. Next up, we have Dr. Samsudeen Hassan Mohammed. Dr. Mohammed is a Google DeepMind Academic Fellow, an advanced research fellow from Imperial College London, and a senior lecturer at Bayero University, Kano. He builds award-winning language and emotional recognition tools for low-resource languages, a co-founder of Hausa NLP and the Awera Data Science Academy, where he mentors upcoming developers in Kano. Welcome, Dr. Mohammed. And then Dr. Blake, who I'm so happy to be here, is an associate clinical professor and director of the Global Health Undergraduate Program at the University of Maryland School of Public Health, a digital health equity advocate, health community specialist, and she focuses on culturally tailored, community-driven approaches to health literacy across Africa, the Caribbean, and the United States. She was also once recognized as a White House champion for change. So thank you, everybody, from my panel for being here. And one thing to the moderators, I am having a hard time actually seeing my panelists. Okay, I see everybody now. Sorry about that. So I'm gonna start off with Professor Maravati. I have a question for you. What we're going to do is we're going to go through a question for each, and then we will have some open-ended question, and then hopefully we'll have some time for take questions in the Q&A, because I'm sure this panel is going to drive a lot of questions to the Q&A. So starting off for Professor Maravati, you're recently coming home from the 2026 Deep Learning in Dublin in Lagos, where the focus was, of course, sovereign intelligence. You have long argued that Africa shouldn't simply wait for the world's biggest AI models to come, but should build smaller, locally trained models. And for health specifically, we understand that many of the more homegrown and trustworthy AI tools will be successful in our environment, right? But one thing you also have been really successful in is even while maintaining a very clear stance in the importance of sovereignty in this technology, you've been able to attract Western investment and engagement in your work. And so I would like for you to tease out a lot more about how we understand the risk of African health data becoming something that is extracted rather than owned, but also talk more about that line between maintaining the importance of sovereignty in our data and our AI systems, but also maintaining a certain level of global competitiveness.
Sure. Thank you. Oh, I just wanted, might have not read my notes completely. How much time do I have so that I don't want to go over?
You have 10 minutes.
10 minutes. Okay. No. Thank you so much. It's great to be here, and it's Maribate. So I'm speak Tsonga. My surname is Tsonga. So the V you pronounce it like a B. So it's Maribate. It's great to be here. Yeah, I'm still recovering. I think a lot of us are still recovering from Lagos. At least my voice is back, so I could join this and actually be able to speak. And I will also share a link to my thoughts about how Lagos was, and for people to understand a bit more about the deep learning in Daba. But I can jump in thinking about, what does sovereignty mean in this space, and then if we're thinking about health and looking for parallels in language, what could be the things I suggest to people? So ultimately, I think sovereignty is about freedom of choice or having agency. So I take it when sometimes I introduce myself, I say my personal mission is how do Africans have agency in making choices about AI during these revolutions, right? So being able to choose. So it's not just being required to only go one direction because you have big players who are telling us that you should only listen to us, which is the unfortunate kind of situation that we typically have. But then it's just allowing those choices. Now, in thinking about language is very fascinating, and I'm pretty sure same thing you will say about health data, in that it captures so much about who we are, the identity, culture, history. All of these things are like encapsulated in the way that we communicate, we keep our oral histories, all of these things. So for example, I started in this area, I tended to think just about the technical. I just want to build models for A, B, or C. Why can't I do it? And then as you kind of really try to resolve the challenge of like, why, if we have 2,000 to 3,000 languages on the continent, most of them are not served by language processing tools. And I'm not talking about AI in this case, like even the simplest, do you have digital dictionaries? Do you have spell checkers for those languages? Things that we take for granted, like in the high resource languages, but those things aren't there. And once you start tracing how we get to the area, the current state, that's when you will have discontent. So if you're really solving the problem, I will argue you become an activist because then you go in and you say like, what this comes in is that it's very socio-technical. There will be a reason that you don't have any digital tools, you don't have data, you don't have these, and a lot of them are just going to be about people. It's not going to be on the technical. So if a researcher says like, I'm going to work on African language, natural language processing, and I'm only going to do this by changing the math and the algorithms, I will always say to them, good luck, right? Because you are already limiting yourself in what's actually possible. So you're going to have to work a lot with communities, understanding their needs, understanding how they think about their kind of cultural artifacts or cultural, wealth, and what it actually interacts with you. So for the larger African languages, it might seem easier because, again, it's typically now, hey, these transcend borders and all those things. But then when you come to a language that maybe has, let's say, 50 speakers, it becomes very, very personal, right? You have to really go go kind of down. So you have to then think about, how do I navigate all of these spaces that I'm thinking both of something that might be regional or country or level, but then at the same time I need to go down to that personalization to individuals and how they think about what language, how language comes in. You might have that there's reasons that people do not share data or digital artifacts for different reasons. And maybe AI has made it worse because now they believe that, like, there will be a belief that if I release my data and make it open, or not even make it open, just make it available online, somebody's going to come and take it, do something with it, and I'm not part of that conversation. Right. And then they might go off and make money, but then they also might represent me and all of these, like, things that come in. So sometimes when thinking about working with linguists, we try to understand these pieces of like, oh, there are actually instruments that you can use. So even if like in the open science, open data environments, you need to know that there are things like licenses, and these licenses can be enforced and you need to engage with them. So some of the things that we've been doing is helping law scholars come think about new licenses that are better suited for kind of communal work. So you might have, if you go to the Maori in New Zealand, licenses that then say like, you cannot use our data without permission. And when we do give you permission, we might require the participation of our community members in the research or in the work that gets done. You might have some who are pushing and saying, we want complete, free as in free, so a CC0 license where there's no acknowledgement about where the data comes from, and which then communities might not want to go into. And this has been shown, like it hasn't, it's not sustainable. You can read about the kind of Mozilla Common Voice project and some of the challenges they had in being able to get voice data, because people after a while when they're like, I'm donating my voice, but then all the identifying information, which sometimes might be very odd, given if I'm talking about health data, but the information that just says that I contributed to this project is completely stripped. So it just looks like there's a data set, and this data set kind of fell from the heavens, and then you can use it, and people don't want to use that. So for our lab, we me in this case, contributed to 2 licenses. So one is the Nulato Obodo Open Data License that comes out of the Data Science Law Lab at the University of Pretoria. And then at our company, Lalapa AI, there was the ESETU license that worked to say, how do you balance between those things? You want to get people to innovate, but you want to be able to protect communities, that if you have a big player who wants to use things for commercially, they should then talk to the community about the beneficiation. And beneficiation does not necessarily mean money, but it's what the community thinks might be useful for them in exchange of using their data for commercial purposes, right? So that is kind of one as an example. The other is that when we're working with different stakeholders that we're trying to either say, hey, how do you become part of this research? What is actually a benefit? For a lot of researchers, you're just thinking, hey, but then my outcome, which might be a model or a paper, it's you can be part of this, you can be on the paper, you can be referenced in the model, but is that actually useful? Right? Is that something that the other parties, the communities that we think we're working on, actually view as actually a benefit that they're getting within that space? So how then do we work with communities to figure out what those might be? You'll see a lot more and more projects now are remunerating for participation. And then there are other things that Deep Learning Indaba, Dr. Helena, one of the lady who won the PhD award for this year, talked about how in her work in Ethiopia, what they were doing is also doing active mentorship, CV writing, career planning that was assisting the participants from those communities. That is for them to feel something that's a direct benefit, even though she was working on something that had to do with natural language processing, right? So you might say, no, these are disconnected, but it's like, no, again, we're thinking about how we leave the communities better through our processes of doing R&D or doing innovation in this area. And maybe then the last thinking to tie all of this together, we do not, unfortunately, if we're thinking across the African continent, yet have kind of a single market, right? The reason it might actually be easier to interact with the EU is that you kind of know your data storage, your data transmission laws, all of those things. while across like the African continent, there might be differences. Sure, you might have consortiums that sign up or sign on to ethical and responsible and sustainable methods on doing their work, but then it's not necessarily might be if it's completely coordinated across countries. So I think, and I'm okay being proven wrong in the comments because you are the experts in this case of thinking about what's been happening at the moment with the US and health data and the exchanges, is that it completely shows this example, right? Because then what happens is that then organizations or other nation states will use arbitrage, right? They will just say, if you're not going to give us your data, we will then remove some benefits that hurt you, and then we will give those benefits to other people and then make you feel like, oh, you should give us what we want. And this removes agency. That is not a choice, right? You are basically blackmailing people into this, and these will have long-term ramifications, and we're hoping that goes away. And the reason I want to highlight this is that even for the people who might be here who come from natural language processing, this happens in language. This happens. There's projects that I might have said no to, but then you find out they show up somewhere else. And then you ask and say, but what's the benefit of doing this project really for the communities that we're trying to serve? And you find that this arbitrage happens even with very big organizations, and that behavior kind of has to stop. But yeah, I think I'll stop there. The rest we'll get through as we chat.
Yeah. So one thing I like then and pulled from that is that language is extremely personal, right? The way we interact with language, the way that we communicate with others is extremely personal, but also our health is really personal. And so when we're interacting with people's data and just people's health experience, right? The way that they go to interact with their doctor, the way they interact with the systems around them that define their health. That is something that's extremely personal. And without a certain amount of buy-in from the patient, all of this kind of falls apart anyway, right? Dr. Muhammad, right? So some of your work with like the brighter data set and Afri-sentiment has established a real benchmark for how we look at sentiment and emotion analysis across dozens of low-research languages, many of which are in the African continent. Medical misinformation and health system distrust are key barriers to care at all communities, right? But as we're focused on the African continent, we know that is an issue here as well. And so recently, we've had many instances where health information and health information distrust have been key barriers to care. How close do you feel like we are to using some of the tools similar to like Afri-sentiment to be able to identify instances of medical misinformation and health communication, right? That's either being shared through social media or through common language information. And do you foresee some of these tools being able to be rolled out into communities, into clinics, into health systems to be able to not only just identify misinformation and sentiment that's being spread, particularly on the internet, but also to be able to create even more trust between communities and health systems?
Yeah, thanks, Malcolm, and thanks to Professor Bukosi, who is a longtime mentor and collaborator as well. Afri-Senti and brighter data sets are basically benchmarks for sentiment and emotion that we work to create on African languages. Basically, a couple of those, when we say African language, it's not like, the complete. In African language, we say we have over, 2,000 languages, and these benchmarks are basically on less than 20. So they are just a couple of work on this benchmark. But I think to point about your work, you are talking about disinformation and other stuff. So Afri-Senti and brighter data set are basically not actually a proxy for, about detection for misinformation of data. But obviously, one of the close work we did, and which I think is the basic obstacle we have underneath this problem on even detection, is that today, AI basically cannot understand these languages, not only these languages, but when you talk about the domains such as health. So for example, one of our recent work that we did, basically called AfriScience MT, what we did basically was that we try to understand if AI can be able to understand scientific content, scientific terms in these languages. So if, for example, we have the AI cannot be able to detect something that is written in local language, which is scientific, then we will not be able to detect, misinformation. So our work called AfriScience MT, what we did basically, we translate scientific papers into African languages, and we try to create terminologies. Obviously, as of today, as we said, African languages, we have over 5,000 languages. What we found that many of these languages do not even contain scientific terminology in local languages. One of the clear examples we have is when we have the issue of Ebola, that we have COVID-19. During COVID-19 in Africa, many countries struggle to disseminate information in local languages. And in fact, they even try to use AI to try to translate this, information, disseminate this information into the community. However, AI tool fails to translate, the COVID-19, which are medical information to, local languages. So this work exposed the current gap we have in AI that will not be able to translate. But also, if AI cannot be able to translate to understand these languages with the domains, with the terminology, then it's difficult for it now to detect, misinformation written in local language. But if it is written in, in English, that's fine. It can be able to translate. But people from Africa, obviously, we have our culture, we have our language, and a lot of people, some of them in particular community, they don't speak English. They speak the local language. So as of today, our languages are not supported in scientific community, but also therefore they cannot be able to, detect misinformation for that. Another thing you made mention about how close are we now in trying to make this tool to be able to detect. Well, what I can say is that obviously we do have 5,000 languages in African languages, and if we have 5,000 languages in African languages, how many of these languages are now supported? We do have data set. That's a real question. All of the current work in African languages, they support 20 languages, 30. Maximum of the work you see, there is no work that support 50 languages, African languages. That means these languages are still lagging behind. They are still under-resourced. The current NLP tool are not supporting them. So we are not, I don't have a particular, timeline that I can say how close are we to close this gap. But I do believe one of the key important things that the community work that we are putting, people without funding, without money, they come to create data set. People that care about these languages create this data set. For example, current work that we are doing is detecting misinformation, but detecting misinformation is not about health wise, but we are detecting misinformation in political domain. But so therefore creating this kind of resources will ultimately, make the timeline to say these languages can now, achieve in not distant future. So that's for that. Another question you asked, I think you said, the question is, what challenge do you foresee in attempting to scale these analytical tools as developers attempt to move from the research lab into real clinic? Well, I think one of the challenges I see here is that even the adoption of this tool. So for Africa, if we create resources, how are you sure that these tools are now being adopted, for example, in clinics, they are being adopted in hospital? Because there is a gap between researchers, as currently today, between the researchers and also the medical expert. So this, I think, one of the challenges I foresee, this connection between medical expert and also the NLP researchers in our community. So this is a little, I think, again, and I can take over the chat.
Yeah, and that's one thing I really enjoy about having both you and Professor Marbati in this space is the ability to be able to like kind of tap in some of the leading minds in research in NLP in a space that is focused on health. And I think there is somewhat a disconnect in large part because some of what I'm taking from your comments is that so much of what we would like from the interaction between AI and the health consumer is founded on the ability for it to be able to communicate to it, for the model to be able to communicate to the consumer. But if we don't have the underlying data systems, right, or even just the digitization of language, as was previously stated, that makes that foundation that we need to grow on, somewhat shallow, and we need deep roots to be able to grow these models. One additional question that kind of just popped into my head that I apologize, I didn't think to send over earlier was, you have House of NLP, which is an opportunity to be able to deepen the bench of researchers who are focused on natural language processing and particularly Hausa, right? What are some of the best practices that you feel like you have gained from the creation of what is, I think, a research institution, in kind of bridging that gap between the amount of data that we have on language and the research that we would need to be able to do to be able to create, effective and robust uh, natural language processing tools and models to be able to like address real world challenges, both when it comes to political sentiment, but also health information, health literacy. Have there been any particular like good lessons learned that you think that would be worth sharing around creating a research institution in that framework?
Yeah, I think one of the I think lovely things to have to be able to solve this is to create a kind of synergy, looking at the health and also expert in NLP, that they work together, try to solve this particular problem. So, for example, now in our community, speech, I think this is one of the important aspects that I think that has gained a lot of attention in terms of health domain. For example, some of the work of our colleague, some of them are startup. They are now actively working on speech collection for African languages and creating speech model for African languages. And these speech models have been deployed in some hospital, and they are doing a lot of things. So I see the advancement or improvement in speech language models, but in text, in terms of text to detect anything concerning medical, anything concerning the health. I think there is still work on that. And one of the key things to do is to create more data set similar to speech that we have now. I think for speech now, we have many languages that are now involved. They do understand been deployed in hospital, but for the text-based language models, I think we have a lot of gap to fill for African NLP community. Yeah.
Okay, thank you. Now I'm gonna shift to Dr. Blake. So you recently had a February op-ed where you argued that I love this quote, if you're not seen in the design, you won't be protected in the outcomes. And that, model solutions from Kigali can inform solutions in Baltimore, but they must be locally tailored. When we see people building AI for local communities, right? AI language models that could be used to be able to better inform local communities, like, some of your fellow panelists. What are some of the things that you feel that these tools genuinely need, right? What are some of the things that you feel that in order for health literacy tools to be like effective complements to care, effective complements to health communication, what do you feel like they need to be able to improve health literacy and trust in real communities, rather than, very well researched and very capable demos? What do you feel like would be necessary to bridge that gap?
Well, thank you, Malcolm and IME, for the invitation and this wonderful conversation so far. I think to answer that question is to really build on what's already been stated by Dr. Marabati and Dr. Mohammed. They focused a lot on talking about inclusion and harm reduction. And we already know how what happens when communities don't own and don't understand the sovereignty that they need to have in their lives when technology is introduced and when these tools are introduced. It usually shows up as patients being really sick, and they're sick because they're not getting the care that they need. Patients being underdiagnosed, because they don't know the severity of what they're going through. So what we need, to your question, what we need, not just from those initiatives, those innovations, but from just the people that are in this room, who are working with these different tools, is one, co-design from inception, right? We heard earlier a lot about working with communities and partnering with communities, and that is important, but it needs to be from the very start. And that really looks at the cradle to grave model, which is pretty profound on the African continent. It actually, that model originated there, making sure that all of the partners in the health ecosystem, like the community health worker, the clinician, the technologists, the elders, the people that hold and protect the culture, they all need to be a part of creating tools and preserving the language from the start and throughout the technology that is being used. This ensures that the problem is addressed appropriately and that the community is not just used as a source of extraction or a source of just mining data, right? The second thing that I think is extremely important is being able to make sure that these systems have a built-in feedback loop, right? So again, going back to the community and making sure that the community is working with the creators of these tools, not just with development, but also with review, with shaping it, with correcting it, making sure that the local languages, the local cultures are built in. And that in and of itself ensures that we are building in trust. It really speaks to the explainability and the accountability that is required for these systems to actually be effective. And my upcoming work and research is going to speak more to that, right? It's going to study how we are taking language skills, how we're taking the understanding of just AI in general, and how we're applying it to communities, particularly how we're applying it in the workforce, right? So that it can really take the languages, the dialects that we're already using, and have it be more effective with the tools that we're using. So if you're thinking about the Kigali to Baltimore principle that you mentioned earlier, that I had mentioned in the article, it really is about making sure that knowledge is flowing freely, which was mentioned earlier, that communities are keeping stewardship, that communities are keeping capacity and the benefits that was also mentioned earlier, and that we're building the trust that really comes from the community, because the community now is a part of the development. The community, they know what the limits are, and they're now able to correct it. So I'll stop there.
Thank you, Dr. Blake. You know, one of the things that I think has been mentioned by all of you is the potential that if done correctly, you know, multilingual AI, natural language processing has a potential for, you know, to be an amazing tool, right? But I think what each one of you has mentioned is the possibility, and not the possibility, but the current reality of a need for just a lot more investment and resources. I kind of want you all to kind of each take an opportunity to name one thing that, you know, if it's not present within like the next, let's give it a limited time, like the next 2 years, right? What is that one thing that you feel like in the next 2 years we need to be able to have concrete, in process, in development, and deployed in order for the growth of, natural language processing within our health systems to be something that is a net benefit versus a net, um, a net negative, right? What is it? Better governance, right? Is it really like just ensuring that there's a very rigorous licensing, like Dr. Marabati said earlier? Is it a lot more investment in research into text based in analysis, like Dr. Muhammad said? Or is it really like kind of systematic structures for co-design, right? That ensure that communities are forefront in the research. Can each of you kind of provide like what do you think a critical linchpin is needed, or what a critical linchpin is that would allow for there to be, greater benefit from AI and natural language processing over the next 2 years versus, the opposite? I'll go ahead and start in the opposite order. So go ahead, Dr. Blake.
I would say there needs to be a shift in from digital health literacy to digital health fluency. And I'll go in a little bit about explaining the difference here and why that's important. Literacy is focused on the ability for you to decode, whether you're using reading, comprehension, or writing. And fluency is more focused on how the ability to really confidently act on what you know, on the information that's being decoded. And most of the tools and most of the natural language processing systems that we have is built for literacy, which is fine, which is good. But I think we need to start graduating from that literacy piece and trying to reach through and focus on fluency. And the way that looks in policy funding and technically looks a little bit different, right? So when we look at the technical piece, if we really want our communities to have the impact that we want to see, we have to make sure that the tools are low bandwidth, offline, and focus on building those things that are not that goes beyond voice and text, right? Many of our African languages that was mentioned earlier today by one of our panelists, many of our African languages are oral, they're not written, right? So if we are only focusing on text systems or text-driven systems or SMS or writing or the languages that are seen most widely across the world, then we're missing out millions of people who may not read very well, may not even read in their own local languages very well. So if we have a wide variety of tools that go beyond voice and text, that would be a really great way of increasing the capability of understanding some of the tools that are necessary. And in and of itself, those things are languages, right? Those systems are utilizing a different type of language. In policy, it can look like making sure that we have assessments or ways in which to really evaluate impact, right? And transparency. Especially when you're talking about the public health system or setting, we need to make sure that the NLP systems that we are using are really serving our communities and particularly the communities that are often left behind because many of the tools are not that we use are not really geared towards a local language or a local context. And then lastly, when we're looking at funding, when we're trying to shift from literacy to fluency, it looks like redirecting money from just building and integrating to dissemination, to deployment, to evaluation, to really community capacity. So what that would look like when it works, that looks like making sure and seeing people actually use these systems to restore trust, not only with the tool, but also with, or the system, but also with health professionals. It looks like better presentations or outcomes for the community that's being served. So being able to close the gap between the reality and the tools that, or the systems that we use, really relies on making sure that we make that transition to improve trust by not just focusing on literacy, but shifting to fluency. So
Yeah.
I'll stop.
Yeah, and before Dr. Mohammed starts, I think there's a through line between something that both of you have said in the last couple answers is, it's important to engage the actual workforce to a certain extent, right? One thing that we, as a part of IME, discovered as a part of some of our work that we're working on recently is that the biggest gap that so many of our last kind of decade of international development has had, particularly in this digital health space, is a absence of knowledge transfer, right? And so if there isn't that concept and that rigorous level of knowledge transfer from the onset of digital health implementation, whether we're talking specifically for AI and natural language processing, or we're talking more expanded to EMRs and EHIs. If knowledge transfer is not a part of the plan from the beginning, you're automatically kneecapping the amount of sustainability and impact that your project can have in that sort.
And
So,
not just transfer, but applicability, right? Being able to apply what you learn, what you get from the data is very, very important. Very, very important. And NLP systems are a part of being able to apply what we learn.
yeah. Dr. Mohammed, what's one thing that you feel like is necessary, a necessary development in the next 2 years, in order to allow for natural language processing tools to be a net benefit, specifically in the space of health and on the continent?
Well, I think one thing, let me say two things as well, that we need to take into account. The first one is about the kind of, I always goes back to data. So when we want to solve this problem, one of the key things we need to look into is about the data. Do we have enough data to solve the problem we have? For example, one of the first questions you ask is about, detecting misinformation about, health-related stuff. But when it goes back to the AI itself and it doesn't understand those languages, then there would be no issue, no way to detect. So one of the most important thing I think we go back is always going back to the data. I think how can we be able to create data not only for handful of languages in Africa. When we talk about African languages and we say that we try to solve those problems, only few languages have been involved, but there are many communities that, they don't have even the researchers working on that. Those languages are being they are not being, tools and data set are not being developed. So one of the key things I think I will say, and the major blockers, even though there are a lot of progress, is that government, especially for government in Africa, is to support or give funding to researchers working on this, because most of the funding coming to African NLP researchers that are developing this tool, this data, come outside from institutions outside of Africa. So, for example, funding coming from Google, from Microsoft. These are institutions that are funding research in the African continent. Now, if we look back and sit down and say, okay, we have this problem, why can't we fund, this and try to solve our own issue? So I think one of the key things is still data. We need to fund researchers working on this space to create more data. And thanks to house of many funders such as Lacuna Fund, who started working on funding creation of data set, including health data set in Africa and continent. One of the first ones for me as well that I got is from Lacuna Fund, and that's how they changed the landscape for Africa and NLP. And more recently now we have Masakani Language Hub that are now funding data set creation, language, and many other things related to African NLP. And I think in the next couple of few years, the story will change. Where at this moment, all the African languages, we call them, language behind, according to Joshi et al. All the African languages we categorize from 1 to 0 to 5, and 0 is the least, what we call language lag behind, and all African languages, mostly except 1 or 2, they are not in those 0 categories. So if all the African languages are in 0 categories, then how long do we think they can now leapfrog from 0 to 1 to 2 stages up to the 5? The 5 stages is what we call high resource languages such as English. So I think there is a lot of work to be put to uplift African languages from 0 categories up to high resource languages. And one of the key things I would say is that is funding for work on these languages. Number 2, one of the key things we have been working on and what changes is, community, work. So some of the work we did, for example, at Masakani is a product of community that comes together, that love this, their languages, and now comes together, develop the data set without any fund, and now, try to make data set available to anyone. So I think one thing that you asked is, I will always is data set and funding from institutions in Africa to help the researchers to develop what we really need.
Yeah. Thank you, Dr. Mohammed. And that's one thing in bridging between you and Dr. Marbati that I truly respect, and I want to highlight it, is that you two are both institution builders. And I think institutions are what kind of allow for not only the ability to attract that investment, but also to ensure that investment is used in a way and stewarded in a way that is productive and effective. Finally, Dr. Marbati, what is your linchpin point that you feel like needs to happen, linchpin action that needs to happen in the next 2 years in order for NLP tools to be able to be used in a net effective way in the future for Africa?
Okay. So I think we've heard the part about working with communities as from the beginning. It's an important piece, especially trying to think about what ultimately are useful things. The current way of thinking about language is this thing of everybody has to have an LLM. They're important to build and they're important to kind of explore, but it doesn't mean, for example, if you're sitting in a clinic that might be in a rural area that has intermittent internet access, that's the best use actually of everybody's energy. There might be things that are much simpler that have to do with language that enable better communication between nurses, doctors, and patients, allow for better kind of information gathering, those types of things that don't need that as much. And literally, when I say energy, it's literally human energy, the electricity, everything that goes into those spaces. So why I'm highlighting this is because then if we're thinking about what's scalable in the next 2 years, it's going to be very contextual to different people, different regions, different languages, different needs will then say, this is what we need. Now, given that, there's I'll say something that's very interesting. So if we go back, maybe 2020, 2022, 2023, I had this thesis of saying you know what, there's so much funding that's been coming into African AI. Unfortunately, a lot of it is not coming from Africa. and as such, the Deep Learning Indaba, Masakane, all of these groups are going through this honeymoon phase that I thought like 2020 would have stopped, but it accelerated actually during COVID, just because, again, capital needs to find somewhere to go. And now it was these opportunities to work on like things like shared tasks. And this exploded during the period where everybody was kind of at home. And I used to use the example actually of health research in Africa, and saying that we should be very careful about this period of glut, right? Where it looks like there's more and more funding coming in, but it's not coming from the continent. Because the thing is, when the organizations, the development agencies ultimately decide that this is no longer something that they're interested in anymore, that money will be pulled out. And that's going to be a challenge. So we should, at this time where we do have that this funding, make sure we're building more and more and more redundancies, encouraging changes in the way funding structures work. And that's a thing I think ultimately is important in both. So it was unfortunate for like now seeing this happen in real time in health over the last 2 years. It was like, for me, I was like, I was using it like, as a warning to the AI community. But then seeing what has happened because of a change of administration in another country that then has ripple effects all over the world, again, like, it's something we should take in. So one of the big things I've been an advocate of, and why joining either the UN or Smart Africa has been on pushing for Africa has to keep on increasing how much of their own R&D expenditure comes from internally, the continent. South Africa at the moment is at 0.6% of our GDP, or 0.67, I think, or something like that. It's the largest on the continent by quantum, but it doesn't even meet its own internal goals. The South African goal is 1.5% of R&D for everything. I'm not saying AI is special or anything like that. The African Union's benchmark is 1%. No African country meets this. Right, and then you compare this to the US, where you should be about 3.6, and I think Shenzhen in China is something at 5% as one province, and 95% of that comes from the private sector. It's also not just thinking about governments. I think a lot of times people just think it's governments who are supposed to be putting in this money. No, in Shenzhen, 95% of it is coming from the private sector, right? Because we know there's more than enough evidence that the bigger the expenditure on R&D per country increases health, well-being of the citizens over the long term, and we need to get that done. So for me, that's the linchpin. Like, if we can get that starting to have a trajectory that goes up, there's a lot more than of having researchers who are based on the continent experimenting their way forward. And then we're not going to say we have 2,000 to 3,000 languages. So thinking that all of them are going to be covered is not necessarily realistic. I might, like, the reason I might have fingers in many pies, so one I'm at a university, so I can think about 2,000, 3,000 languages, but then my pace might be slower. While at a startup company, maybe I might think about 50, but I might move faster, right? And then in governance, at the UN and other places, you kind of increase then what's available as things that have to change over a period. So because revolutions are both fast and slow, there's things that you need to do now. I mean, it's been great working with Shamsuddin and a lot of other people in this area, but then there's things that even if we're not there, should still be going on. And that's going to require the changes that are going to be there for generations way after us, that then enable them to go. So that is the thing. Don't take this as pessimism. For me, I'm a very optimistic person. It's just that I'm highlighting of saying, these are the hard things that are going to have to be done.
Yeah, no. I think the most optimistic people are the ones who are able to identify the details that are missing, right? That's a personal belief of mine that I hold on to wholeheartedly, because the ability to be able to identify what is needed between the reality and the desired goal is how we actually can be able to realize some of our optimistic aspirations. And I love to kind of give this summary of that last question. We have both community engagement and the transition from fluency, from literacy to fluency. I love the grounding that was given in identifying the need for, like, hey, we need more data. And then in order to be able to make that, any of that work, is we need to be independent and transparent in the amount that we're willing to invest into the future that we want. I know we have just a couple minutes left. If there are any questions that anybody would like to pop into the chat, this would be the time to do so. I'll give it another minute before we do that. And not seeing any additional questions in the chat, I will like to say thank you to Professor Marbati, to Dr. Mohammed and Dr. Blake for your insight and your participation in today's panel. And I will pass it back over to Dr. Brown and the IME and host team. Thank you all.
Thank you so much for this enlightening panel discussion. Very important. I do have one question before you leave us. What about training, and how do we, for the individuals that are not as technologically savvy and may not understand how to work the system, is there any training that a general person in the community might be able to partake on as we are talking about some of their health information being utilized in these platforms?
That's a really great question. I'm going to jump in and just answer it from my perspective. I think this is where institutions really hold accountability for that, right? So many institutions, universities across the diaspora and also on the continent, they have trainings or guidance, health guidance for community members to either learn a little bit more about these systems or to learn about organizations that can provide support and assistance to better understand. So I would turn to your universities, to your local community organizations that are partnering with these universities to get more resources, more health guidance, so that you learn not just about the tool or the system, but also about how it's applied and it's applicable to your own personal situation. In addition to that, I think also when you're thinking about training, you have to look to those who are working in governance to provide more context about how and how these systems are actually being applied, how safe they are, how your safety is being protected within that. And you can go to, at least in the United States, you can go to your local delegate or Congress representative in the Caribbean or on the African continent. It's usually those who are working at a health department that can assist, and typically with community organizations that are working with the Ministries of Health that can properly assist with how things are either being governed or can put you in the right direction with those who are responsible for that. So I'll stop there.
Thank you so much. Are there other comments? I see Dr. Maravati put something in the chat.
I was going to say from the parts of maybe as an AI researcher, there's always a massive what's this interest, especially from those coming from health and what AI could do. And one of the reasons we started our AI Institute at our university is to help people from other spaces actually move into these areas as well. And again, as I said, like experiment in a responsible and sustainable way forward. So the last link I have is just, we had a seminar series last year on basically AI and health. And a lot of it is coming from people who are practitioners in the space, not me. I'm a pretender in the area. I always join projects mostly as trying to help out. And then there's also the Sisonge Biotech. I think maybe their LinkedIn is the best. I posted that also slightly before. That then has it's a consortia of healthcare, especially practitioners who work then with machine learning as well. And right now at the Deep Learning Indaba, they had their own workshop. So they're very active. And then the other one is it the DSI consortia that ran for a couple of years on health. And unfortunately, again, due to funding cuts, given what's happened, I'm not sure how, it's still continuing. I've given talks at this consortium as well. It ran for big meetings. So there's data science for health discovery innovation in Africa. I'm pretty sure there's many people who are here who are likely connected to this. But then for those who might not know, that's another place that you can connect to people who are working in those areas. It's always reach out, ask, even to me, and then we will connect you with these different communities that are working in these areas. I think that's one thing that's been very exciting about the kind of African space on AI is just the buildup of grassroots AI organizations that have worked to fill in gaps that yes, typically would think either large national organizations or kind of big multilateral institutions would be the ones that are building that. But then that was not necessarily what was needed at the time. So now you had a huge kind of explosion of these more localized solutions.
Thank you so much. Yes, I was trying to get to those at the community level that's not covered by government, et cetera. So thank you for having those. And I think unless there are other comments, I think we're at the break time. So again, this is the stand up and shake around, have some water, restroom break. We will come back in 5 minutes. I believe that is our time. If we can put our clock on, that will put us right back on time. So thank you all so much, and we will be ready for our third panel. No, our fourth panel. Excuse me, yes, our fourth panel. So again, talking about the strategic partner roundtable. So 5 minutes, stand up, shake those legs, raise those knees, take a deep breath. We have to take care of our physical health as we take care of our mental health, as well as not from a mental standpoint, but from a physical, emotional standpoint. Thank you all so much for being on the webinar, and we'll look forward to this next panel that will talk about some of the partnerships that we have and where we can improve going forward. So break time. Thank you so much for putting our clock on to let us know when we're coming back. Thank you.
Dr. Brown, this is Conrad Clyburn. I'll be the moderator for the next panel. And if I could be joined on video by Mr. Niraj Shadar, Mr. Bugami from Helena, and Dr. Kong, Professor Kong from the University of Toronto, will be ready in about 1 minute and 45 seconds.
Thank you.
Okay, this is Conrad again, moderator for the next panel. And if Mr. Bagumi, the president of Helena, if you could join us on video, that'd be great. And I don't see Professor Kong. Hopefully he'll join us as soon as he is available. And I'm at 5, 4, 3, 2, 1. Okay, we'll get started with the next panel. My name is Conrad Clyburn, and I am a advisor with International Medical Exchange with IME. We're joined today by Niraj Fedar, who is a go-to-market leader focused on partnerships and the adoption of digital public infrastructure solutions through the Google Cloud. Most interestingly, and this is we've got a great panel today. He returned recently to Google after a secondment to the Indian government policy think tank NITI, the National Institute for Transforming India Commission. And at the commission, Mr. Hadar served as the resident fellow, the founding member, and the lead architect for the Frontier Tech Hub, working on India's readiness for frontier technologies across the board. So we're very pleased to have him with us today. Mr. Sothenis Bagumi is a digital health and health informatics leader with more than 16 years of experience in health information systems, human-centered design, project management, and implementation. He's president of the Tanzania Health Informatics Association and serves as the principal ICT, Information Communications Technology Officer for the Tanzanian Ministry of Health, where he's focused on digital health systems, health data usage, governance, and the strengthening of health service delivery. Most recently, Mr. Bugume has also been elected as the president of Helena, the Pan-African Health Informatics Association. And so we're very pleased to have him with us today as well. Hopefully we'll be joined, or we have been joined just recently, by Professor Jude Kong from the University of Toronto. He's accepted the invitation, and we're assuming that he'll be able to join us. He's assistant professor at the Dalai Lama School of Public Health, with cross appointments in the Institute of Health Policy, Management, and Evaluation, and the Department of Mathematics, where he directs the Artificial Intelligence and Mathematical Modeling Lab. His work combines AI, data science, mathematical biology, and infectious disease modeling
to support decision-making in public health, government, and in communities. And during the COVID-19 pandemic, his multidisciplinary team worked in nine African countries using AI and modeling to inform containment and response strategies. So with that, I'd like to welcome our panel. This panel is focused on the intersection of strategic partnerships across sectors, academia and civil society, industry, and government. The previous panels quite often have touched on the importance of engaging government, of leveraging civil society, of the importance of industry and the sustainability of these advancements, and in the changing models that are occurring internationally in terms of funding. So what I'd like to do is just to start out giving each of the panelists 5 minutes or so to describe their work. And since they each sit in a different corner of what we sometimes call the triple helix or the quadruple helix of academia, civil society, industry, and government coordination, to talk a little bit about what they see as the biggest current gaps and how these sectors work together on AI in African health systems today. And if there are gaps, how do we close them, and whose responsibility it is to close those gaps between academia, civil society, industry, and government. And if we could start out with Mr. Hadar, coming from the industry perspective at Google, and also leveraging his time in advising government. And Mr. Hadar, if you could come off mute, if you could kind of share with us your thoughts on the intersection between the different sectors and how they can work most effectively, bringing AI to health systems.
Awesome. Awesome. Conrad, first of all, thank you very much for the very generous introduction. And my thanks to all the organizers for getting this amazing panel together. Really appreciate this opportunity to exchange thoughts and facilitate exchange and continuous work on this very important topic going forward. So thank you for that. My warm wishes from India to everyone who is joining this webinar. I want to talk about this on two parts. Let me spend a few minutes talking briefly about what our team does and the role that DPI or digital public infrastructure can play in aspect of health, but also many other population scale problems. And then I'll come to the part of what's the role for technology, and as you said, Conrad, what are some of the constraints and challenges that various stakeholders have to solve. Very briefly, I represent the Google Cloud Digital Public Infrastructure team. We are powering a very important initiative from within Google. Some of you might be familiar with various digital public infrastructure implementations in India, which have been at population scale. The two most famous ones are our identity system, the Aadhaar system, and then our payment system, UPI. And the basic thinking, if you have to strip this down to the bare basics, the basic thinking with DPI is that as the government or a custodian, you build infrastructure similar to other physical infrastructure like roads and ports. You don't define, when you build a road, you don't define which cars and which bicycles and which two-wheelers and trucks and buses can run on them. The custodian builds a road to say we have to connect cities. And then various use cases have been built on top of that. When roads were built, probably nobody would have thought that one day we would have shared mobility like Uber and Ola and Namayatri in case of India and so on. But the road was a very common infrastructure that was built. And in many of in our identity systems and payment systems in the country, we have applied the same analogy, right? How do we build an infrastructure on which innovation can happen? So the bare minimum protocols, etc., are defined, and players in the ecosystem then build on top of it. So that's the work. That's the work our team does, and in particular. And in fact, let me also connect this with some of the work I was doing back when I spent a year at Niti Aayog, where one of the pieces of work I was involved in, along with other partners, was on what does the future of DPI look like. So identity and payments are the fundamental layers, but how can we leverage this concept of DPI to facilitate better livelihoods, to facilitate better economic outcomes for people? So how do we go beyond just a financial transaction to the exchange of value? And this exchange of value may be in education, it may be in healthcare, like we are all gathered here today, it may be in agriculture, it may be in terms of finding, matching the demand and supply of skilled jobs, and so on and so forth. But how do we extend that to beyond the exchange of just financial value? And as Google Cloud, we saw that there are two big friction areas to solve for. One is that for a custodian like a government or for a service provider to come on board to a digital public infrastructure network, or what we commonly refer to as an open network, while all of this is open source, it is often still a technical overhead, technical effort to have a network live or to come on board to a network. And our engineering team has built middleware which reduces this technical effort. That's part one. But part two, and at least equally, if not more important, is how do people access these networks? And that is where our other intervention, which is an agent, which is a reference agent, with which the end user can speak with the network, and any service that is relevant to the user can be surfaced back to them. So that is what our team does. And there are, as I said, there is one aspect which is about how do we reduce the technical overheads. There is a second aspect about who do we put at the center. And I choose my words carefully here. I'm not saying what, I'm saying who do we put at the center. So in case of health, for example, how do we put a patient at the center and solve for their problems? Now, a patient might require various different things during their life cycle. What is the easiest way for a patient to get access to that? And irrespective of where they are located, how remote they are, how do we make sure that the best-in-class healthcare becomes available to them? If you think of a clinician, if we talk about most geographies in the world, particularly in the global south, clinicians and providers struggle with excessive load. They struggle with management of data. Again, how do we build a system where everything that a clinician or a provider might need is all accessible to them in one place in their voice? So the second aspect is about who do we put at the center? And then there is a third aspect, which is around how do we reduce the user interface. It's easy for many people sitting in this room to use apps or use even multiple apps at a time. But what does it take for us to say that the effort of accessing healthcare should be so low that everybody in the population is able to easily access it? So that's the thinking of how our work is built. I'll get also to the second point that you made, Conrad, around what are some of the challenges or friction areas, particularly as these 3 or 4 different stakeholders across industry, academia, civil society, and government interact with each other. And I see that there are, I would like to articulate this in 3 T's, right? There is trust, there is transparency, and there is traction. Trust is the aspect of all these stakeholders working towards the same set of goals and having full faith in each other that they are bound by a common set of goals. Transparency is the accountability to each other and to these end users, the who that we are putting in the center. And then there is an aspect of traction, which is about how sometimes these 3 or 4 stakeholders tend to move at a different speed. They are solving for a different set of motivations. Sometimes they may be solving for a different set of end stakeholders. They are all governed by their own cycles um, uh, of business, for the lack of a better word. And the way I see it is that there is a 4th T, which is technology, which can actually solve very well for these 3 T's of trust, transparency, and traction. I'll pause there, and I look forward to the rest of the discussion.
Yeah, well, thank you. I hope that you have not trademarked that trust, transparency, and traction.
Our team champions open source and open networks. So
okay,
not at all. Those 4 T's are open to be built on further by this group.
All right, thank you. I think that's a very important message. So the next question is for Dr. Mr. Bagume. The same question, which is you have visibility on all 3 of those sectors of civil society. You're the president of Helena. You work within government, and through Helena, I'm sure that you interact quite often with industry. Could you also comment on how do you think the sectors need to be working together to advance AI responsibly in health systems? And then secondly, from your perspective within the Ministry of Health, what is the differentiation you see between successful pilots that become part of the national infrastructure and those pilots that go into what we call the valley of death, after the funding ends? And if you could just kind of comment on those 2 questions, I'd appreciate it.
Thank you very much for your good question. I also concur with the past speaker that the balance between the government, academia, private sector, and CCOs, they all depend on each other. They all accomplish the concept known as quadrilepsy. So, for instance, the CSO private sector, they normally move faster than the government move. The innovators, Gen Z, they're tech savvy. They move faster than the government move. So, for instance, in the era of industrial revolution, like the AI, blockchain, and the other technologies, the government really moves slow according to this technology they're new. So they come up. Mostly the innovators, they move faster, more than the government moves, and they depend to each other. The government depend on innovators, innovator depend on the government, and the CSO as well depend on the government and in the backside. So there is the only tricky issue is, in order for innovators, they write a model which they produce. In order for them to go to commercialization, they need to be regulated. There is a balance, the second balance the government needs to play to vet the algorithm which the innovators used, or the CSOs used, the private sectors used, and see the threshold of the particular threshold of this particular algorithm, if at all that particular threshold is judged or is being vetted as a good AI or mediocre AI. Or is it safe for human consumption, or at least the threshold is not safer? So such a kind of check of balances have to be done, especially in the African government, African sectors, especially when you deal with the sectors. But there is a gap. The gap which is there is that African government programmers, they lack, or there is an insufficient knowledge of programming of AIs of AI models to African sector programmers. So what the cooperation should be done is the CSO, private sector and academia should capacitate to where the government programmers to capacity whereby they can be able to vet these algorithms of AIs. And also collaborate in a way that we all participate on our mutual goal of making sure that we save lives at a safer and a benefit-driven mechanism. So that's the first point. The second point is you asked about the from parotitis and the value of death. The best pilot which can graduate to being a skilled pilot is the one which involve the users from the start, from the development of that solution, so that the government or the business users can gain ownership and they can see it. Their ideas have been put into practice when the system is running. It's a best change management practice, and also at the end of the project, there should be a successful exit strategy to make sure that there is a sufficient handover and sufficient capacity to the government to uptake the solution. So even if the project might be ending, but the government must see the value, can also appreciate the value of the project or the solution, and they can see maybe the need to invest in such a solution for sustainability. Those are the two kind of issues. But also, and maybe let me end up there before I proceed. Thank you.
Well, thank you. That was a very important point, which is that the end user needs to be involved from the beginning and not the end. Well, I think this kind of circles back to one of the questions I had for Mr. Hadar, which is that Google, works at the macro scale, at the digital scale. I think Mr. Bugame just made the point that it also needs, these solutions need to be valuable at the local level. And that is something of I think a little bit of a tension there between, how do you scale digital public infrastructure, for example, at the national level and still ensure that it is relevant at the local level. I throw that out to Mr. Hadar. Is that a challenge that you have seen in your work of dealing with both of those priorities?
Yeah, this is a great discussion, and thank you for your comments, Mr. Bagume. Thanks for the question, Conrad. I think there are two ways to look at it. I wish I could say that, yes, this is a known problem and we have solved it, but unfortunately, I can't say that. I think this is a known problem in many aspects and many different sectors. There are solutions, or there are processes we build in one geography or in one sector, and we want to translate those to others, or we want to scale it across geographies, and that is not always straightforward. But I think there are a couple of thoughts here, and a few dimensions that actually make the entire digital public infrastructure approach very well suited exactly to this problem. So revisiting some of what I said earlier, right? Like if we are true to the principles of digital public infrastructure, the idea is we strip down the infrastructure to the bare basics. The infrastructure should be as limited as possible, but the infrastructure should also solve some common horizontal problems across sectors, across geographies, and so on. And then you are allowing the ecosystem, which is often going to be local, if not always, it is often going to be local, to use those infrastructure elements and build on top of that, right? So for example, if we had to solve for, say, in case of healthcare, if you think of it, we have to solve for electronic health records. We have to solve for having a registry of all the different providers, whether they are primary care providers, whether they are sellers of medicines, whether they are providers of diagnostic tests, and so on. Then we need some sort of a data exchange so that these systems can talk to each other. Now, if you think of these basic building blocks largely will remain the same between multiple different geographies, and I would argue even between multiple different sectors. You could build a parallel of this in another sector like education and say that I need the same set of things. I need electronic educational records. I need a record of identities for the set of people who are involved. You need a record of all the service providers that exist. The exact stakeholders would change, yes, but the construct of the building blocks is largely the same. So we have to strip down the infrastructure to the lowest common, the bare minimum infrastructure that is, that is required to facilitate the innovators in the ecosystem to build on top of that. And the second thing I would say here is also that right from the beginning, we have to start thinking of trade-offs as features almost. Because when you're solving at population scale, you cannot address a trade-off after you have already scaled it to hundreds of thousands or millions of people. So how do you start thinking of these as features? For example, not everybody in a country may have access to a smartphone. Maybe in another country, the smartphone penetration is higher. Maybe there is a third country or a third state where the penetration of where the mix of languages is different. Now, if you treat this as features, you say that, hey, if I'm building any AI agent, which is something I think the entire world thinks that AI agents are the answer to every problem that exists. But if you are building an AI agent, how can we make sure that the first dependency of the AI agent is not a smartphone and a 5G super fast internet connectivity? That same AI agent should also work on a chatbot. The same AI agent should also work on a toll-free number or an IVR. In fact, I would go to the extent of arguing that there are some geographies where people don't even have access to an IVR number, and they are going to say a government-run or an NGO-run service center. The same AI agent should be able to speak to the systems being used at a physical service center as well. So I think we have to start thinking about trade-offs as features that have to be built into our solutions from day one, rather than solving them as trade-offs after things have scaled.
Thank you. What I think I'm hearing is that simplicity is at the core, that scalability need to be built in, and that modularity or features on top of a simple interface that is scalable is important. So thank you again.
That's a great summary, Conrad.
Okay, so we'll again use that going forward, and along with the 4 T's. And so I think the last question for Mr. Bugomi, as the president of Helena, you have uniquely visibility on multiple countries and their health informatics stakeholders. Are there any examples that jump out to you of successful best practices in the strategic partnering between these sectors, academia and industry, and government that you would like to share with the attendees?
Thank you very much for a very good question. The best example which we've done so far is the scaling the convergence workshop. The philosophy of convergence workshop started back ages in Asia. Then we took from as arena to scale up to other African countries. To date, we have done it for more than 3 countries in Africa, and we are pursuing resources to scale up to others. The philosophy of convergence workshop is in each individual African countries. Most of them they do have the digital asset strategies, in which the digital health players along the within the respective countries, they do plans. For instance, the development partner plans for according to the digital strategy of the country, as well as the implementing partner, private sector, academia, and the government. But however, these plans, they're being done individually, maybe individual in one IP, individual in one DP, individual in one government, in their places. As part of parallel planning, some of the activities that are being duplicated, and some of the resources as well that are being duplicated. So the convergence workshop essence is to bring together the varied partner, implementing partners, private sector, government, academia. You bring them in one venue. You table the analysis of the digital strategy, and you do a joint planning together. So you come up with a joint implementation roadmap for the country, which avoid duplication of efforts and activities, and also maximize the value of resources in a low resource setting. So it's a very effective approach, and we have done it. And over the recent, I think it was in July. I think it was in July or August. July. It was in July. The Asia eHealth network, they've been capacitating the South Africa to come up with a global solution for South Africa, supported by Global Fund. So it's a very effective approach by bringing together, having a joint implementation plan, and being signed, endorsed by the government to be used in a certain country. Those are the very effective approach which we have done so far in Africa. And we're also thinking along the lines to jump to the previous question which you spoke about, you asked my fellow speaker. I was thinking around about using the high performing digital public infrastructure which Google has developed, and maybe trying to solicit collaboration with the African Union and using the African Union mandate so that we can scale up the digital public infrastructure for African member states, the EU member states, maybe for use cases like the disease surveillance and diagnostic use cases. It can be very applicable to you to deploy somewhere to maybe for we call what projection, maybe to see this outbreak of disease, maybe by using this data, which outbreak is almost seamless to occur. So those kind of initiatives also to be very good. Thank you very much, Speaker.
Oh, thank you. Yep. Thank you. So we're at the end of our time for the strategic partnering roundtable. I would say that we have had a number of important points made by the speakers. The 4 T's of trust, transparency, traction, and technology, I think, is important. Simplicity, scalability, modular features. The point that Mr. Bugami made, that the sectors need to come together at the outset. Not only from a planning best practices perspective, with academia, civil society, industry, and government at the table, but also that the end users need to be at the table at the beginning, so that what may be a pilot initially, can transition into something that's part of the infrastructure overall. And then Mr. Bugami's last point, which is worthy of consideration, of looking at maybe there's an intersection between a government coordinating body like the AU and digital public infrastructure, to look at some compelling use cases going forward that would really have an impact uh, on a regional and a multi-country level. So with that, I'd like to thank our panelists. Mr. Hadar, thank you for staying up late in India to
It's
join
my
us.
pleasure to be here. Thank you, Conrad.
And President Bugami from Helena, thank you for joining us from Tanzania, and we really appreciate it.
You're
And with
welcome,
that,
Conrad.
I will turn it back to Dr. Brown and for comments from the co-chair of International Medical Exchange, Dr. Henry Musenge, as we move towards closing.
Thank you so much for that engaging conversation. I particularly appreciate that sort of four-pronged approach of needing trust, transparency, traction as we look at technology. Very important. So I think we're coming to, and I don't see the agenda up again, where we're going to have sort of closing remarks, as well as there are some questions that we've seen in the chat, and I think I'm trying to get on. Let's see. I would like to ask if there are questions. Maybe Josie has some questions, but I sort of pulled out a couple of things that might have passed already, and I will ask those questions. And for anyone of our panelists that would like to address that, please respond. One of them, what is the impact of the macro impact of large language models and generative AI? What will it have on the African environment, economics, and power dynamics? If we would like to have one of our panelists to respond to that. I think that might have been covered by the panel group from Malcolm's group, but others can weigh in if possible. And
maybe let me chip in from the health sector angle.
Thank you so much.
Yes, large language models have got a very good impact in making sure that they bring precision medical care. For instance, when they're used at medical consultation, whereby larger language model is being embedded within the EMR, and it can also translate speech to text, and also within the instance of large language models, clinical guidelines can be embedded there, which can learn according to the medical history of the patient. Then language model can drill down and see within this medical history, these are the kind of diagnosis should be done. And within this medical results, these are the kind of medication should be done according to the standard treatment guidelines of a certain country. So it is very usable and very useful to giving a second opinion to a medical doctor in a fraction of a second, for seconds, such that then the doctor can confirm or affirm that this the kind of diagnosis I should offer, or this is the kind of medication I should offer. So it has got an advantage of bringing precision in medical care as far as digital health is concerned. Thank you very much. This is the one impact I know.
Thank you. If there's anyone wanting to add to that, please do. I'm just trying to run through a few questions here. One question is, if we are already lagging behind in terms of technology, et cetera, how can we fill the gap? Is there anyone that would like to respond? If we're behind from a technological or digitalization of our healthcare on the continent, how can we catch up? Any takers on that question? Surely you don't want me to call on someone.
Dr. Brown?
Yes.
Yeah, this is Yunkap Kwenkam. I'm not sure this is I hope this is a satisfactory answer to the person, but the question makes me think about how, in general, low and middle income countries or less rich countries adapt to new technology. And one of the advantages that these environments have in terms of new technology is the absence of any inertia that will hold them back. They have a lot less inertia in terms of legacy systems. And in the old days, we spoke about leapfrogging certain technologies. Like in Africa, we had so few telephones, landlines, that when the cell phone came up, there was very little to throw away or to get rid of. So the adoption of cell phones was very rapid indeed. And I think in areas like AI and health, the same experience or the same thing could happen in that we have a lot less there's a lot less we're tied to through experience and what's available on the ground, that we're able to adopt new systems more readily. I think that's one advantage. I'm not sure it answers the whole question, but I see that sometimes being far behind is an opportunity to leap even further ahead.
Thank you. Very wonderful question, response to that, that we could leapfrog and be in the advanced stage. I like that. Another question, and I hope Shabaka is keeping time for me as I review. One question was, how do we regulate the regulators? Which is kind of interesting if we talk about government having controls and regulating certain areas. So who regulates the regulator? Who wants to respond to that? I know there was someone from WHO and Helena and some of the other areas that might want to comment on that. And don't everybody jump in at one time. Let's see if Professor Malenga, are you still with us?
I know we had one of the members of my panel talked about that component. If I got the question right, regulating the regulators in the space of AI, obviously, it's very obvious that government will really come in very strongly to make sure that things are in place. And where such systems are not being formed, I'm sure this is an area where government will be looking at very closely and
formulate systems that will make sure regulation is in place. I know for the general digital usage in many African countries, this is coming through, but for specific areas addressing issues like health, which can be sensitive, as you know, even in research, we have specific regulation that occurs in that area. That will come definitely. And that has to be taken into consideration. Thank you very much.
Thank you. And then I'm going to, before I introduce Dr. Malinga, one final question. Let's see. And of course, we talked about data protection and data security. And I think those are very important issues. The other one, is there a centralized pathway that we could use as a control for accrediting various bodies? And that may be difficult if we are looking across countries, and interoperability may come into play there. So anyone want to try and address such a complex question? Governance, protection, security, and all of those issues that are around establishing our AI programs.
Yeah, this is Yunkap. I'll take a stab at it. I think this is where the model that we've always talked about, and the evolution from the triple helix to the quadruple helix, where government has a role to play, industry has a role to play, academia, and civil society. Civil society has an important role to play. And the whole thing runs well if there are good, strong democratic institutions in place. Because the regulator, even if government is the regulator, it cannot go off on its own if it's not responding to the needs of the people. And you see how some of the principles that WHO is advancing, first of all, issues like One Health. In other words, the health not only of humans, but animals and the environment. The next major principle there is health in all policies, because our health depends on so many things, depends on everything that happens around us. So all other sectors of the economy. And to manage all of this, then we need very strong institutions. One of the weakest that, in my personal observation, has been that of the professional bodies. In some of the English-speaking African countries, you have medical and dental councils that sort of act in the same role, I suppose, as the American Medical Association. That sort of a professional body that regulates the profession, following government laws, of course. So we need institutions in that space as well, as far as technology goes. And so currently, the professionals in this space have very little say in what happens. They're at the mercy of government inviting them to participate. But if these institutions, as they get stronger, they can begin to not only advise government, but even dictate to other sectors, how things should evolve. So I think the professional bodies have an important role to play here, and I'll stop there. You're muted.
Excuse me. Yes, thank you so much for those wonderful response to the questions. I would say that we certainly will have whatever was in the chat as well as a Q&A, and try to respond to some that we may not have had the opportunity to cover. I would like to present our closing speaker, Dr. Henry Masenge, who is the chairman and co-founder of the International Medical Exchange. He has decades of leadership across many industry, science policy, as well as higher education, having served as the CEO of the Zambia Horticultural Products Limited and chairperson of the Zambia National Science and Technology Council, as well as vice chancellor of Trinity University. So he is a published author and lead research consultant. So Dr. Masenge, we will ask you to close us out. I think he's still on the line. I'm looking at my participants. Mr. Olisa, can you determine if Dr. Masenge?
Yeah, I'm calling his number to make sure.
I don't see him on the line
No,
anymore.
I think he came in under his name. So
okay.
Yeah, when he uses his link. So
I see two CCs logged in. So one of them.
Conrad, is he perhaps on one of your lines?
I don't know.
There's a Conrad Clyburn and a Mr. Conrad Clyburn. So maybe he's on one of those.
I do not see. I'm going to then ask Mr. Olisa to close us out. Mr. Olisa, I will ask you to close us out. I do not.
he's here. I have him. Henry, can
Okay.
you log it? Can you just use the link and come back, and we're waiting for you. Yeah, can you use? What did you say? Use the same link. Just click on the same link.
While we're waiting for him, I would like to certainly offer my thanks to all participants for the questions that we have in the Q&A as well as the chat box. The questions were very insightful as we plan for upcoming webinars, as we again get ready for the conference that's going to be held in the spring of 2027. And of course, I see a number of individuals that are interested in collaborating with the IME. And certainly we appreciate that because we want to have a very robust and dynamic group as we tackle digitization on the continent, and it is very important for us to work together in a collaborative mode to bring about this. As we are starting maybe a little late from a technological standpoint, but we are, as Professor Yankum has indicated, we're going to leapfrog some of the ones that were in this space earlier as we move forward to bring all of the information. Mr. Olisa? You and Dr. Masenge, Professor, Dr. Masenge.
Hello, Henry. Okay. Just on Mr. Dr. Mosenge's behalf, I'd like to thank each and every one of you, especially the speakers and the panelists and the moderators, for dedicating your time to prepare the speech that you presented today. And for those participants that are still left with us, I know that we had over 200 plus when we started. And because of time, some of them left. So even though they are not here, I want to extend my spiritual regard and greetings to them. And for those that still remain, I thank you for your dedication and your commitment. And for Mr. Heather from India, I know that Mr. Clyburn did acknowledge his patience and the time he gave us. I want to once again thank him for staying up late. Dr. Brown, you pretty much covered what I was going to remark on in terms of the upcoming event. As you have indicated, this is a prelude for the main event, which will occur in Morocco under the leadership of Professor Dr. Hassan. I think Dr. Hassan is still with us. So after this, we're going to put him to work to make sure that the Morocco event is more successful than ever. So I thank you. I do know that Professor Juncker wanted to make a remark before, so he can close out that. Is Dr. Mosinge with us? Dr. Mosinge? Okay, Professor Juncker, I hand over to you. Thank you again.
Thank you, Mr. Olisa. There's a huge hazard speaking after the closure of a session. So I know I'm taking a major risk continuing to speak after the session has been closed. But I did want to say something about momentum. Remember at the beginning of today, we talked about building momentum in all 54 African countries for AI for health. I think we've had a great start today. And the next event is not in Morocco next year, but online in 2 months. Or no, maybe 3 months, because November, there's going to be another event of this type, all in preparation for the major in-person conference that we'll hold in Morocco. So one thing about momentum, it does obey Newton's laws. And Newton's first law says a body continues in its state of rest or uniform motion until impacted upon by an external force. Momentum is pretty much like that. There are forces out there like, other things interfering, our memory, lots of things can happen between now and when we have the next session. So we have to maintain a positive force on this momentum.
Professor, can you hear me, Prof?
Okay.
Yes, I can.
Can you hear me?
Yeah, we can hear you. Dr. Mosinge, we can hear you, even though you came under CC's name. Yeah, so he's with us. You can continue, Dr. Mosinge, before we lose you again.
Yes, I agree.
The symposium chairperson, the IME CEO and co-chair, Mr. Basil Olisa, the leadership of the International Society for Telemedicine and eHealth, all distinguished participants, ladies and gentlemen, it gives me great pleasure to join you today and to say a few words at the closing of this important online executive symposium. IME was founded in 1997, largely through the efforts of Mr. Basil Olisa and a few other colleagues. Some are with us today and others are no longer with us. But I want to thank them all, even posthumously, for their efforts and to assure them that their efforts to found this organization were not in vain. And today's symposium and the planned activities, one of which was alluded to by Professor Jacob, and the face-to-face meeting delegates who stayed with us throughout the symposium. I want to say thank you very much. This has been an important meeting held online across many timelines, It worked because you all chose to be present and engaged rather than half listening in the background or even walking away. That choice in itself is a signal of the momentum we have created today. We have therefore affirmed that frameworks and political will exist to enable our organization to make an impact on African health. From the AU's endorsement of a continental health data governance framework, and to Africa's and WHO's global push to equity-oriented AI in health, we said what was missing was a continental momentum at the level of the 54 individual health systems belonging to 54 different African countries. That is what today's engagement was largely built to move. Today, we have listened to our experts. We have aided them discussing various aspects concerning the role and importance of AI in African health. From the experts' exposition about the application of AI for health purposes in Africa, it is appropriate to say that hearing it echoed back by delegates from government, from academia, from industry and civil society, from across our continent and beyond, rather than simply asserted from a podium, is the strongest evidence, in my view, we could ask to illustrate that frameworks are right. From frameworks to action, dear delegates, as we close, we should ask ourselves a simple question. Where are we? As IME and the International Society for Telemedicine and eHealth and all the other partners, they are taking today's discussion and turning it into a shared statement of continental priorities, and not a communique to sit in an inbox, probably to gather dust, but a working document we shall carry directly into our own ongoing engagements with institutions like WHO, Africa CDC, and the country health ministries. In essence, that means three things going forward. Continuing the technical partnership and capacity building work already underway through our institutional collaboration. Using the connections made at this symposium today between countries facing similar constraints and between delegates and our respective networks as the start of follow-up conversations and not the end. Returning to this community with concrete progress reports and not excuses or just another symposium. call to action. To each participant, I wish to call you to action. Take the specific entry point you identified for your own health system and treat it as an assignment and not simply a takeaway. The organizations convening today are ready to continue to help carry out this momentum forward. However, the next move in most cases belongs to you and to your national teams. To our fellow non-state actors and technical partners on this call, the coordination challenge across all African countries is bigger than any one institution. Therefore, where your mandate overlaps with ours, we would rather collaborate than duplicate. It is important, therefore, that we reach out to one another. To our hosts, our panelists, and everyone of the countries who joined us, I want to say thank you for making today more than just a webinar. The frameworks were already in motion before this morning, or this afternoon, or this evening, depending on your location. What truly changed today is that this room, this platform, this continent moved with them together. Finally, on behalf of IME and the International Society for Telemedicine and eHealth and all other partners, I wish to thank you most sincerely, and we look forward to continuing this important effort together. I thank you.
Thank you, Dr. Mosengi, for your kind word. And Dr. Brand, we turn it over to you to conclude. Thank you, Dr. Mosengi, again.
You're welcome.
Again, this is a thank you for staying on for those that could, and for all of the participants, including those behind the scene that really helped to make the technological aspects of this move as smoothly as it did. We appreciate you very much and thank you. We look forward to the next webinar in a couple of months, as well as the continuous planning for the spring conference in Morocco. Thank you and goodbye.
Thank you. Thank you, everybody. Yes.
Thank you,
See
Chair.
you. Bye.
Bye-bye.
Thank you. Bye, Dr. Mosengi.